Good morning, everyone. Good morning. Thank you. Thank you so much for joining us. And welcome to World Family Doctor Day Conference 2024. I hand you over now to our moderator for session one, Prof. Marvin Reed, CCFP Regional President. Prof. Reed, over to you, sir.
Morning, everyone. Morning, colleagues. Welcome to this iteration of our conference or webinar. It's indeed a pleasure seeing you all online. Many of you may be aware that yesterday we had an awards ceremony, which went very, very well. And on behalf of the Caribbean College of Family Physician Regional and the Caribbean College of Family Physician Jamaica, we'd just like to thank you all for your support over the ensuing years. We recognize that World Family Doctor Day, it's really a collaborative event, celebrating the work that as family physicians we do, but also celebrating with our patients and with all our stakeholders who enable us to interact and be of service to them. The webinar today, organized by Caribbean College of Family Physicians Jamaica in association with the Association of General Practitioners of Jamaica and the Family Medicine Unit of the University of the West Indies, is focusing on a problem that we expect to mushroom over the ensuing few years, and that is about mental health. This occurs within the context of a global World Family Day theme of healthy planets, healthy people. And within that broad global context, the Jamaican group has decided to focus on mental health. We have a distinguished panel of speakers to share, to discuss. We're hoping to be as interactive as we possibly can. And more importantly, as moderators, we're going to be hoping to keep us on time, on schedule for the rest of the program. So within that context, the program highlights that we will start now with a prayer by Dr. Andrea Perai, who is the Vice President and Chair of the World Family Doctor Day Organizing Committee. So may I invite Dr. Perai to open the word of prayer for us.
Good. Thanks, Professor Marvin Reed. Okay, guys, let's bow our heads and pray. Heavenly Father, thank you for all you have given us and the many blessings in our lives. We thank you for the opportunity to gather virtually here today to celebrate World Family Doctor Day 2024, and for the tools and resources that make this possible. Thank you that we can come together as individuals with different gifts, ideas, strengths to pursue a common goal. As we begin our conference, we dedicate this time to you, asking for your guidance, wisdom, and support. Help us to engage in meaningful discussion, allowing us to grow closer as a group and nurture the bonds of community, nation, and world. We pray for the presenters, attendees, drug company sponsors, committee members, Secretary Ms. Lim, and also Ms. Suen Lawrence, and IT personnel, Mr. Harold Sam, who made this conference possible. We pray for your guidance and wisdom as we listen to the presenters so that we may be receptive to new ideas and perspectives and can learn and grow together in knowledge and understanding. May your presence be felt throughout this webinar, and may it be a time of fruitful discussion and learning. I ask that you fill each heart with your presence and grant each mind clarity. Help it engage with the material presented and apply that we can learn to benefit ourselves and our community and to help fulfill the mission of WONCO, which is to improve the quality of life of the people of the world. In closing, may we do as your words say in Colossians 3, verse 17, whatever we do, whether it's in word or deed, do it all in the name of the Lord Jesus. Give thanks to God the Father. Through him, we ask these things in your name. Amen.
Oh, thank you so much, Dr. Perai. Very well done indeed. All right. So as we move forward now and with the program, it's indeed my pleasure to invite Dr. Aileen Standard-Golson, former director or coordinator for the postgraduate family medicine program, to give greetings and welcome.
Thank you very much, Professor Reed. It is my honor and privilege to bring greetings and welcome you all on behalf of the World Family Doctor Day Jamaica Committee. I take the opportunity to wish all family doctors online a very happy World Family Doctor Day. As you may be aware, the designation of May 19th as World Family Doctor Day was initiated by the World Organization of Family Doctors, WONCA, in 2010. In 2015, the insight and vision of Dr. Arnold Brown Morgan saw the establishment of the World Family Doctor Day Jamaica Committee. It comprises of members from the Caribbean College of Family Physicians Jamaica chapter, the Association of General Practitioners of Jamaica, and the Family Medicine Postgraduate Program, UWI-MONA. Over the past 10 years, we have put on various activities to mark the day. There is an annual CME activity which has occurred uninterrupted even through the COVID pandemic. World Family Doctor Day was the first group in Jamaica to mount a virtual CME conference in 2020. And this has now become the norm, allowing a wide range of health professionals, not only in Jamaica, but across the Caribbean, to access first-rate CME activities. We have also done a number of outreach activities and a yearly World Family Doctor Day printed supplement. For the first time this year, the publication will be a virtual one, accessible on the CCFPJ website as of May 23rd, 2024. As you heard, we had an awards dinner. Well, we had an awards dinner in 2016, and last night, over 20 stalwart family doctors were recognized in different categories at a stellar awards dinner held at the Hotel Four Seasons. It was good to meet again in a spirit of camaraderie and celebration. Today, we meet to continue our quest for knowledge and to share in intellectual discourse. WONCA's theme for World Family Doctor Day this year is Healthy Planet, Healthy People, and speaks to the importance of planetary health. We also recognize that mental health is an important component of health, which was severely impacted during the COVID pandemic and beyond. Our theme today, preparing for the mental health explosion, the role of the family physician, is therefore a timely one. On behalf of the World Family Doctor Day Jamaica Committee, I welcome you all, and I'm sure this will be an enlightening experience. Thank you all for being here.
All right, thank you so much, Eileen. And I will now ask Dr. Paula Henry, Vice President of the Caribbean College of Family Physicians Regional, to bring greetings and welcome as well.
Thank you very much, everyone. And thank you, Prof. Reed, and thank you, Eileen, for that very warm welcome. I am Dr. Paula Henry, a family physician and a planetary health doctor from Trinidad and Tobago. I will now share my screen. This is how I would tell you about what we are going to do today. We're going to talk about climate impacts, mental health, an island plunged into psychological trauma. And this is the island of Barbuda after Hurricane Irma in 2017. We're going to focus today on the impacts of climate change, which you will see here. It could be anything from heat waves all down to degraded air quality. But our focus today would be on hurricanes. Just to remind you where Barbuda is in the archipelago, And this is the eye of the hurricane passing over the island of Barbuda. We are going to look today, looking at things from the exposome, the perspective of the exposome, and we're going to look at the impact of exogenous factors, endogenous factors, and how coping mechanisms will actually affect the mental health and the well-being of a population. We know, of course, that modifying factors have the ability to change all of this and to affect outcomes. In terms of the exogenous factors, we are going to concentrate today only on the impacts of climate change. And the endogenous factors, we are going to look at the vulnerable populations because we understand that risks are associated with one's physical health, your age, your sex, your education, and your social economic status, just to name a few. Our behaviors and our coping mechanisms, what we believe, our culture, the type of relationships we have, and social cohesion will all impact outcomes. A community that has great social cohesion and where they use all the community resources to come together to work against a common enemy would always have best outcomes. Modifying factors, we understand, would influence what would happen. And we speak here in terms of access to healthcare, the macroeconomic status, our ability to financing, the adaptive capacity of the system, what policies we have in place, what is the political regime of the day, how much conflict that occurs because of this disruption in society, and the migration and displacement that is always a part of major disasters. So on September 6, 2017 at 1:47 a.m., the eye of Hurricane Irma passed over Barbuda. It was reported to be the most powerful Atlantic Ocean hurricane in recorded history. In a matter of minutes, Hurricane 2, Category 2, progressed to Hurricane 5++, as described by the inhabitants. And they said the wind was so powerful, it felt like we were being blown to bits. The howling of the wind was deafening. The smell of several animals, dogs, cats, donkeys, pigs, was surreal. We moved from room to room as windows and roof were blown away. We huddled together, lying as closely as possible to the ground. We were filled with anxiety and panic, and we turned to prayer. So it was a team of researchers, including myself. We went in February on the island of Barbuda, and our main research goal was to gain a better understanding of the psychological impacts of Hurricane Irma on the inhabitants of Barbuda 6 hours later. And this is what people told us, that during the hurricane, we felt fear, paranoia, phobias. We felt that we were in a nightmare. We felt panic. And there were many reactions going on in our brain. And then came the eye of the hurricane. We became focused because we realized that this was our opportunity to gather all the vulnerable populations in the community and bring them to a place of more secure shelters, because we knew that the second tranche of the hurricane would be even worse. And this speaks of panic and disbelief, because we see here where there was originally houses, there was now empty land, nothing to see, houses blown to bits. So in the aftermath, 90% of the island was destroyed. Houses completely disappeared, no electricity or safe water. Roads were impassable, and the only hospital on the island was non-functional. There was poor air quality, a smell of stench, and even worse, there was a second hurricane looming in close proximity, Hurricane Irma. This is a picture of our Madison Square Garden in the aftermath of Hurricane Irma. This tells the story: ruin, decay, trauma. What was the new reality? Mandatory evacuation. And so you see on the faces here, confusion, chaos, forced migration. The emotions that the people felt were helplessness. They could not go back to secure the food that was spoiling in their refrigerators. And they knew that the equipment in their houses, the refrigerators and washing machines would all be non-functional by the time they returned. There was a feeling of anxiety, sadness, depression, and they were angry with the officials. Relocation to Antigua did not affect every person the same, because there were persons here who were able to go to family members and they were secure, they felt secure in these surroundings. Whereas there are people who had to go into shelters and they were dependent on food and resources from the international community. And believe it or not, there were some people who had enough resources to go into motels during this period of crisis. This is 42-year-old Maria. She had 4 children. She had to live in a shelter. She shared that room with 12 other persons. And for her, this was mental torture. She told us about having food cards, going to get her rations. And she was told, no, you could only get personal items. And she did not have enough food to feed her children, while she observed that there was a pantry full of donated food. Factors contributing to the worsening of mental health immediately after the hurricane. I always think of Haiti. Right after the hurricane, people felt powerless. They felt powerless because they couldn't do anything. And then I remember the story of this young lady. She was told that if she did not return to Barbuda, she would lose her job. So sadly, she left Antigua and she went to Barbuda. She took with her her youngest 2-year-old child, and she almost lost that child to asthma because of the degraded air quality. There were no hospital services on the island that could help her. And this is the aftermath. People could not repair their damaged houses because sadly, there was no home insurance. And how did people cope? Most people told us that they coped with prayer. Prayer sustained them. And they said, how is it possible for an island to have 90% infrastructural destruction, and yet we lost only 1 life? And then people secured their relationships. There was one person who told us he actually got married to his sweetheart lover that he was living with because it brought them together. And so we had a resilient people, because they were filled with gratitude, and they understood that there was better community preparedness in the future because they had already gone through this negative impact. There was an opportunity for more resilient housing structures and health facilities, and that they look forward to better community networking and social cohesion. And they knew that psychological first aid in the years to come, and counsel immediately after the impact, and continued after the disaster would have been the solution. And the lessons learned from this current disaster would educate the future for the nation. Subscribe for more. They only gave me 10 minutes.
And you did very, very, very well, Dr. Paula Henry. Fantastic. So colleagues, many of us who are old enough to have gone through a hurricane can actually relate personally to a lot of the experiences here shared by Dr. Henry. We recognize that many of the countries in the Caribbean are what is described as small island developing states. And the risk of climate change is quite real to us. We recognize that, as with any of the common illnesses that we are associated with or used to managing, those chronic diseases, there are multifactorial impacts related to the social determinants of health, impacts related to endogenous factors, our own mental state, and our own physical health. Paula Henry highlighted in her presentation the fact that, when you have disruption of care, individuals with premorbid conditions like asthma can find themselves in tremendous challenges or difficulties. And that leads me now into the next presentation where we will discuss asthma. We recognize that we're now living in an environment dominated by artificial intelligence, and we're also living in a medical movement where we're trying to establish personalized care. So when we think about the holistic care model, where it is that we try and manage as best as possible, or co-manage as best as possible with our patients and the communities, their individual care, we're now that process is being facilitated by artificial intelligence, which allows us to personalize our care to the individual persons much better. And to bring some insights on this matter, sponsored by GSK, we'll have Dr. Terry Baker. Dr. Terry Baker is well known to many of us here in the Jamaican landscape. She's an internist and pulmonologist, having gotten her pulmonology training in the University of Toronto. She currently is the Senior Medical Officer of the National Chest Hospital and is an associate lecturer in the Department of Medicine, University of the Hospital. She is well qualified, being a member of several professional organizations, including the European Respiratory Society. And it is indeed my pleasure to invite Dr. Terry Baker at this point to share with us about artificial intelligence, how that is going to help us personalize care for asthma. Welcome, Dr. Baker.
Thank you, Professor Reed, and it is my distinct pleasure to share this wonderful day with you and all the colleagues, this World Family Doctor Day, and I'm humbled to be here. I'm going to share my screen. And I trust we can all see the screen. So as Prof has says, we're going to be looking at artificial intelligence and its application to asthma or management of patients with asthma. Artificial intelligence is a blossoming, growing, exploding field, especially as it pertains to healthcare, and not to be left out are our patients who have asthma. So just to disclose, I have received an honorary fee from GSK for the dissertation of this talk, but I'm not an employee of GSK. And today, just to remind ourselves, I'll be looking at what is artificial intelligence, because for many persons, this is an area that is a bit difficult to grasp. We'll be looking back at some of the historical timeline of AI, the application of artificial intelligence in medicine and in particular in asthma. We'll be looking at AI in asthma research and patient care, and then we will close with our final tips and takeaways. So when we speak of artificial intelligence, we're talking about the development of computer systems that are able to perform tasks that would normally require human intelligence, such as visual perception, looking at speech recognition, eventually decision making, and the translation of this information between languages. And there are different components of artificial intelligence, and I'll just mention a couple that are relevant here. We may have heard of the term machine learning, and the big question is, well, how can machine learn? And this pertains to the development of systems that are able to learn and importantly adapt without following explicit instructions. And it does so by using algorithms and statistical models to analyze and draw inferences from patterns, and eventually use this to enable software to improve performance over time. We may have heard of natural language processing, which now is another subfield of artificial intelligence that looks at the interaction between computers and human language. And then there's this deep language, which really is there to sort of mimic what the brain does. So it has many different layers, and it speaks to a network described as a neural network, which takes in tons of data to analyze, and then these models then use this analysis to intuitively learn and apply such learning to various departments or layers in terms of economics, social health, climate change. And so we can use this to predict what is to come or what we have learned from the future. So when we look at the relationship between this artificial intelligence, machine learning, deep learning, and natural language processing, so all of that falls under the umbrella of artificial intelligence. As I mentioned, natural language processing is a branch of AI that teaches machines to understand, interpret, and generate human language, like when we speak to a machine or type to a machine. Machine learning now involves systems that can learn by themselves, so that you don't have to be instructing the machine. You put the data in and it does the analysis. And deep learning now uses models built on neural networks to detect patterns with minimal human involvement. And AI is definitely not new. We may be seeing it in so many aspects of our lives, but AI dates as far back as 1942, when then Alan Turing, well, he broke the German code, and he is credited with having broken this Enigma code to saving millions of lives as it pertains to the World War that was taking place at the time. And then Alan Turing was a mathematician, went on to be testing machines and looking at machines for intelligence and intelligent behavior based on data that was submitted. Then in 1955, we have who is considered the actual father of artificial intelligence. He's credited with actually coining the term of artificial intelligence, and try to look at formalization of common sense. Very interesting, if you ask me. Then throughout the years, we looked at the development of the first, what was then called a chatterbot or chatbot, which we may have used on so many of our interactions. You know, you type in a message and this computer-generated speech response to the question is then prompted on our screens. I'm certain many of us have used chatbots. The first one dates back as far as 1964, which was very rudimentary. Then in 1995, you had the chatbot called Alice, which actually is an acronym for Artificial Linguistic Internet Computer Entity. But I don't want us to bog ourselves down with all of these names. In 1997, there was this big explosion because IBM had developed a computer that they call Deep Blue, which went on to win a chess competition with then the world #1 chess player. Of course, that never went down well. There were accusations of cheating, etc. But it did point to the whole input of data that the machine could analyze and use to play games. Subsequently, we've had the development of robots, which are emotionally equipped. The first one came out in 1998. And if we move forward to 2020, we now have so many automated conversations with our computers using, for example, ChatGPT, Alexa, Siri, for example. So although we're seeing this explosion, just to underscore that this has been a long time in coming, and to appreciate how far back we go with the development of artificial intelligence. And as I mentioned, we I dare say we all use artificial intelligence without even recognizing this is what we're doing. For example, smartphones. I dare say the least we do with our smartphones nowadays is to make a call. We have face recognition, fingerprint recognition to unlock the phone, which employs AI, email, these spam filters that keep out unwanted mails. We have GPS navigation systems, online shopping stores. So when you do online shopping, you may have gone to a site, and then when you go to another page, it will pick sites that it thinks will be pertinent to what you were looking at. The chatbots I mentioned before, and Alexa, Siri, and right now we have cars that are driverless cars. So all of these applications actually have employed AI. Now, AI has also been used in medicine. It has been used to analyze large databases and identify patterns that would be difficult for humans to analyze, and as such has brought to breakthroughs in fields such as genomics and discovery of new drugs and appropriate drugs, and thus personalized treatment plans. AI is also being used in medical diagnosis and treatment, such as analyzing medical images, X-rays, CT scans, and MRIs, and have been shown to have quite a high percent of sensitivity and specificity compared to human analysis of such investigations. It can therefore help to identify abnormalities, detect fractures that may not be seen by the human eyes, early tumors or other conditions, and provide quantitative measurements for faster and more accurate diagnosis. AI has been known to assist clinicians with treatment decisions, particularly in predicting therapy response, and we see this in HIV care and oncology care in particular, and has been used to optimize medication doses tailored to the individual patients. And thus we're moving away from what was considered more traditional medicine to what is called really personalized and precision medicine. So this slide is very busy, but this is just to underscore the application of AI in health, clinical decision-making, hospital operations and management, in medical imaging and diagnosis, patient care and monitoring, ethical considerations and challenges as it pertains to AI, of course, are important. And I dare say, even though it may seem like a lot, there is a definite future of AI in healthcare. As it pertains particularly to the use in asthma, what we know about asthma is that we have such a large number of persons having asthma, over 339 million persons. And it is still a major global problem, and the numbers are increasing. And with this large number of persons, we can understand how AI, in its ability to take data, large amounts of data, and do an analysis that would be challenging for humans to do, then we can therefore apply it in managing patients with asthma and hopefully eventually getting better outcomes than we've been having. So asthma poses challenges that have remained unmet, and some of these challenges include difficulty in diagnosis of asthma, leading to significant underdiagnosis and in some cases an overdiagnosis of the numbers. The whole pathogenesis of asthma is still not fully understood. It is based on this process of gene and environmental interaction. So we have to also look, depending on the genetic makeup of the person or the phenotypical makeup of the person and the environment in which they reside or are exposed, does that impact the expression of asthma in these persons or their risk of developing asthma? Looking at exacerbations, which play a crucial role, right, in the management of persons with asthma. If we can use AI to help to predict persons who are at risk of exacerbations, then we may be able to help these persons and reduce the cost in managing persons having an exacerbation, which no doubt is quite considerable. And then we can look at personalized care and use this in terms of determining our guidelines for management of these patients. So AI may be used for screening and diagnosis in asthma, classification of the patient depending on the genotype, phenotype, and environment in which a person resides, therefore leading to better management, monitoring, personalized treatment, and no doubt it does have a big role in asthma research. And we look at a number of these. When we look at in diagnosis and monitoring, we look at what we call predictive analytics, which is used to analyze large data sets, including medical records and emergency health records and data and genetic information. And this identifies individuals who may be at risk for developing asthma, thereby enabling early diagnosis and intervention. And then there are wearable devices that have been used. I see in UK and also in India, which are AI-powered wearable devices that continuously monitor physiological parameters, such as a person's respiratory rate, heart rate, activity levels. Some of these can even detect environmental changes, thereby detecting early signs or risk of having an asthma exacerbation, thereby alerting patient caregivers and healthcare providers. In terms of the development of personalized treatment plan, we see where AI can analyze data, including the electronic health records and patient-reported outcomes to tailor treatments to these individual patients. And when we look at a genetic analysis now, AI can help interpret the genetic data to predict how patients may respond to different medications, thereby enabling more effective and personalized treatment strategies. AI has been used in predicting and preventing exacerbation by environmental monitoring, integrating data from air quality sensors, for example. Therefore, patients can be alerted to take preventive measures when conditions worsen, and symptom tracking, where AI tracks and analyzes symptoms reported by patients through mobile apps. So you do have mobile health apps that patients may be able to interact with, providing personalized reminders to patients when to take their medication, how to track their symptoms, and how to perform particular exercises, particularly breathing exercises, therefore offering educational content and self-management tips, empowering and enabling our patients really to manage their underlying condition. And then you have virtual assistants. So when a healthcare professional may not be available or persons may not readily access healthcare, these virtual assistants can answer patient queries and provide guidance on management. And just to mention two of the devices that are in use that I found particularly interesting, particularly when we think of persons who are non-adherent to therapy. You have Propeller Health, and you actually have smart inhalers. When you look at Propeller Health, this company is using a platform that analyzes data from inhalers which are equipped with sensors. And therefore, it helps patients and healthcare providers track medication use and identify patterns that may indicate poorly controlled asthma. And as I said, you now have smart inhalers. Now you do have a device which attaches to the regular inhaler, and it uses AI to monitor medication usage. So this would be very important. We can speak about affordability, but it then provides feedback to patients and doctors. And a big area from which all of this can further grow is research and development, particularly as it pertains to drug discovery. AI can accelerate the process of discovering new asthma medications by analyzing complex biological data and identifying personalized potential therapeutic targets. Clinical trials are expensive, challenging to perform, but AI systems can optimize the design and execution of these trials for asthma treatment by quickly identifying suitable candidates, predicting outcomes, and monitoring the trial progress. So that is looking at AI and its applicability in asthma. Now we're going to look particularly at AI in asthma research. And a big area of asthma research is what is called modeling studies. And what modeling studies are, these are simulation studies which use AI. They involve creating mathematical or computational models to simulate and analyze complex systems. And it's widely used across a number of scientific disciplines, as well as social sciences, physics, and health. It was used to understand COVID-19 and its predictability within the recent pandemic. And therefore, it is used to understand behaviors, predict outcomes, and test hypotheses in situations where real-world experimentation is impractical or near impossible. So the benefits is that we can test a number of hypotheses, it's time efficient, it's cost effective, and there's a definite risk in reduction in that we can explore scenarios that might be too risky or even unethical to test in reality. That being said, there are challenges associated with modeling studies. The results at times can be difficult to interpret, especially for more complex models. Of course, the quality of the data is dependent on the quality and completeness of the input of the data, and therefore we speak of accuracy of the data that is being generated. So as it pertains to asthma in particular, this in silico coming from the Silicon Valley, computer-based, we have used it and have seen where it has been used to develop models for pharmacological or physiological processes. And these results are then used for the management of patients. And the beauty of it is that we do not have to involve human participants, but we're taking studies that may be there in our retrospective analysis and doing the analysis. So this is use of computer simulations, including virtual patient cohorts in a controlled clinical trial simulation or in a real world setting, and therefore represents a unique opportunity to characterize the influence of each factor and disentangle it. So this is really looking at personalized care. So here it is. This is just a diagram showing what is modeling. You have in vivo studies, you have in vitro studies, and then you have the in silico studies, which basically analyze clinical trial data, real world data. You have the development of this virtual database and protocols. And through this and applications of various factors, we can then have a number of studies being generated. So we can use modeling studies for predictive analysis, and that is when we use it on existing clinical trial data to simulate future outcomes in various populations. We can use the data and manipulate the data to evaluate a range of possible outcomes and do this at a fraction of the speed and cost of clinical trials. And then these predictive models can be used to guide treatment decisions and personalized care. AI has been used and in research, not just looking at asthma, but in a number of other areas such as oncology, HIV, COPD, nephrology, COVID-19 that I had mentioned before, and in ADHD. And so these are drug disease models which enable the characterization of treatment responses in individual patients based upon the data that has been analyzed. So just to give an idea, a representation, we have various data that may be input into the model study, such as in the instance of asthma, we may put data as it pertains to BMI, FEV1, which is lung function testing, asthma quality of life scoring, and smoking. And when we put all of this data in that may come from different studies, then we have this ability to make predictions based on the analysis and to support decision making. So from this, we have more what we call drug disease models and parameterization, which allows for the information to be reused more efficiently rather than just a blanket guideline as it pertains to asthma management. We can also pick out what we call treatable traits, which we know many of them increase the risk of exacerbations in patients. But if we take out individual traits, treatable traits, and look at its impact in terms of asthma management and care, then we would be better able to treat our patients based on the presence or absence of some of these treatable traits. So this is one scenario. For example, we have a man, let's call him Mike, who's a smoker, BMI of 26, and an FEV1 of about 70%. If we plug his data in the analysis and say, well, let us see if we just give him ICS monotherapy based on what the guidelines have traditionally said, we can see what his predicted exacerbation risk and his quality of life profile over 12 months will be in the first graphical representation. But if we say, well, let us give him ICS and LABA, so now we're looking at drug disease relationships and not necessarily just going by our guidelines, we can see that the predicted exacerbation risk and quality of life profile over 12 months is improved compared to just ICS therapy. So just by choosing ICS LABA, symptoms and future exacerbation risks may be reduced. And one such study that has come out is a master series of studies, particularly master 2 studies, which was funded by GSK. And this master 2 has been able to look at a large amount of data and has been shown through its analysis to be equivalent to systematic reviews and meta-analyses, and has been acknowledged using the FDA and EMA guidelines. So when we speak about the master studies, right, master stands for the Modeling Asthma Treatment Response Studies. And as I said, these are a series of studies that were funded through GSK. And relevant points with regards to the master 2 is that they looked at moderate and moderate to severe asthma, the various patient characteristics, treatment, and through this, they had various clinical trial simulations. So the studies were done. The input data came from 9 studies, and you had over 16,000 pooled population, and from this population, samples were drawn to do the various analyses that have been taking place and still ongoing through the master series being done by GSK. So you have analysis using Kaplan-Meier estimates, which have been summarized both numerically and graphically for each simulation scenario that has been looked at. And the simulations would have been done for a treatment for about 1 year, except one, which was looking at the seasonal effect, which had a duration of about 6 months. And where appropriate, what we call heat maps were generated to explore the effects of individual covariates on the overall risk of an asthma exacerbation. So I know this slide is very busy, but this is what a heat map would look like. So at the top, for example, you see a male figure, you see a female, and then you have along the X, the ACQ5 at baseline, and along the Y, you have the FEV1 or lung function. And when you can then plug in certain data and determine whether it is green or red, red being a higher risk of having an exacerbation. So through this, if we look at the first set of columns, looking at budesonide formoterol, we can see that a female, right, who has a lower FEV1 risk and a higher ACQ is at greater risk of having an exacerbation compared to males. And if we compare budesonide formoterol to fluticasone salmeterol, which is in the last two sets of the last row going across, we can compare, just even looking at the colors for these data, that patients, a female patient who would have received fluticasone salmeterol compared to budesonide formoterol would have a less chance of having an exacerbation. We see more green and red when we can compare the data. And we can see when we look at men, for example, that even fluticasone salmeterol compared to budesonide formoterol, that men had a less chance of exacerbation using the fluticasone salmeterol compared to the budesonide formoterol. So even just looking at this heat map and appreciating where red is and where green is, we can pick out certain traits among these patients to determine what may be a better choice of drug for managing such persons. So one scenario that came out of the Master 2 studies was looking at the incidence of exacerbations at 1 year. And it took, as I said, pooled studies and did the analysis. And what was shown here is that regardless of the level of control, the risk of incidence, the risk of an exacerbation, was significantly less using the fluticasone salmeterol compared to budesonide formoterol. Another scenario that was looked at was looking at the lung function of these persons, and again plugging in the data and comparing the two treatment options. And again, fluticasone salmeterol significantly reduced the risk of exacerbation up to 14.7%, regardless of the FEV1 when compared to budesonide formoterol.
Hi, Dr. Baker, 2 minutes remaining.
Okay, thank you. Again, we're seeing here where the incidence of exacerbations again was less. And so what this has done is to really compare drug therapy based on specific patient variabilities and groups. So the fluticasone salmeterol showed a significant lower exacerbation risk, regardless of level of control, as well as the lung function testing. So artificial intelligence may seem quite frightening, but I would dare say it opens a door of possibilities and really gives us a chance to look at data in a different light, looking at specific drug, disease, patient interactions rather than necessarily blanket guidelines. Of course, data generated out is dependent on what is put in, and we need to also bear that in mind. So we can use it to predict clinical outcomes and detect particular phenotypes, have appropriate level of care for varying groups of persons, and it opens the door for research, making research easier, less costly, and more efficient. And with this can come drug development, which is expedited, and the financial benefits of same. So what we're looking at is really precision medicine, looking at specific groups, plugging in the data, and with that comes personalized care, empowering our patients, and with this empowerment becomes better coping mechanisms, better adherence, and improvement in our patients' well-being. These were the references that were used. I want to thank each and every one of you for being here this morning and being part of this talk. And again, thank you for the invitation.
Thank you so much, Dr. Baker. Rather interesting indeed. And I know there's a lot of concern about artificial intelligence, concerns related both to ethics, to issues related to privacy, and just a general fear and misgiving whenever new technology is being launched. But as I tell my colleagues, I recall when I was in high school, we learned maths using a slide rule. And then by grade 9, the calculator came in and it said that we were all going to be done, so we wouldn't be able to do any maths calculation whatsoever. And no, my daughter doesn't even want to use a calculator. She says, that's so blasé, Daddy. Why are you insisting on not using a calculator? So, you know, it's the same fear and trepidation whenever we think about new technology. You speak about it in asthma and looking at the input data. The risk, as you highlighted in your final slide, is that certainly those of us in the Caribbean really need to ensure that some of our data is captured, because otherwise what will tend to happen is that the algorithm, which is trained on Caucasian European sets of data, may spit out outputs that are not really suitable for patients. And so that's an important observation, that we really need to become part of the global community. We need to encourage our companies to include our data in their training algorithm, so that we can benefit from the advances that's being made in artificial intelligence. Another component, which I know you didn't have the time to go on, is the whole issue of genetic variability. So there are many of these chronic diseases that have a significant genetic variance and genetic variability on it. And by identifying the expression of these genes, we may also add an additional layer in the tweaking of the medications that we're going to be using, or tweaking of the treatment algorithm we're going to be using. We see that more in the oncology field, as well as in the nutrition field. But I'm thinking that in these polygenetic conditions such as asthma, hypertension, diabetes, there's going to emerge an important role for that. Time is fast spent. We're going to try and see if we can catch up sometime for a bit question and answer a little later for you, Terry, because I'm sure within the audience, there are going to be some questions. You're encouraged to put the questions using the Q&A button, and Dr. Baker and Dr. Henry will address any of those questions in the background using the Q&A slots. It's now my pleasure to welcome our next speaker, Dr. Kevin Goulbourne. Dr. Goulbourne is my classmate. We graduated from the same medical class of '88. So he did his training here at the University of the West Indies. Kevin has a special interest in drug abuse treatment and completed a Hubert Humphrey Fellowship in Drug Abuse and Health Services Management at the Virginia Commonwealth University. He currently occupies the post of Director of Mental Health and Substance Abuse in the Ministry of Health, and he has been in this position since 2018. In his past, he has served as the Medical Director of the Medical Services Branch in the Jamaica Constabulary Force, where he has been involved in an ongoing drive to encourage healthy lifestyle and early interventions in treating medical conditions through regular screening of members of the JCF. Dr. Goulbourne is going to be sharing with us promoting mental health wellness in the community, targeting resources at the home, school, and work. Dr. Goulbourne, floor is yours.
Thank you very much, my classmate, Prof. Marvin. I'm sorry I'm not able to show my photograph. I don't know what is up in my video, but I'm sure you can hear me.
Yes, we're hearing you well, Kevin.
Okay, good. So first of all, I must really commend the College of Family Physicians the Association of General Practitioners in Jamaica, and from Medicine Program at UWI, for staging this World Family Doctor Day with a special emphasis on mental health, which underscores for me that these groups endorse that there is no good health without mental health. So I will first of all look at what does it really mean when we talk about promoting mental wellness, the importance of mental health, or mental illness promotion program, and mental wellness within different spaces mentioned earlier, and also what resources there are that can help us to promote mental wellness. So mental wellness, or otherwise called mental health, is one's ability to deal with the normal demands of everyday living, paying bills, taking children to school, going to work. It also involves a person able to appropriately respond emotionally to different circumstances and situations, a person able to establish meaningful and positive relationships, a person able to work and make a positive contribution to his or her community, and a person also feels good about him or herself. So constitute a person who is mentally well. So then promoting mental wellness then is not just limited to preventing mental illness. It also includes treatment, psychosocial support, and helping persons to recover. So the big question is, does mental diagnosis prevent attaining our mental health? Think about it for a few seconds. Is the person who has mental health diagnosis, depression, can he or she be mentally well or mentally healthy? The answer is very resounding yes. Because I'm sure a person who's diabetic and diabetes control can function and fit the slide I mentioned earlier as being healthy. Now, one of the biggest barriers, though, to achieve mental wellness is really stigma and discrimination. And in order to promote mental wellness, we have to also respect persons' rights and uphold persons' rights. And that protection of persons' rights is a multi-sectoral involvement involving education, work, housing, social benefits. Now, the Convention on the Rights of Persons with Disability from 2006 included among different human rights, about over 30 human rights. They include the right for education, the right for work and employment, the right for health. And in the Ministry of Health and Wellness, we are actually looking at the mental policy and legislation reflect above. And it's very important when we look at the recent news item that mentioned unions asking the government to remove a clause from employment contracts, which allows it to dismiss an employee without notice or payment in lieu of notice if they become up on sound mind. Now, let me relate a positive story. A lady who I heard of worked for several years, was interrupted by a diagnosis of depression. She finally recovered, and in her late 40s, she had to apply for jobs. During one of the interviews, she stated to the interviewer that she had depression and a period of unemployment. The human resource interviewer asked her, "Are you taking medication regularly?" She said yes. And she was hired, and she worked up to about 10 years afterwards, and now she earned a pension because she got a chance to continue to work because of her human right to work was honored by these potential employers. So mental health has been considered to be a very important aspect, and women's health in 2022.
Hey, Doc, sorry to interrupt. Do you have a PowerPoint that you're using?
So you're not seeing it? I'm sorry.
No.
Oh,
Can you please share it?
oh,
Sorry about
sorry, I'm sorry. Yes, sorry about that. Let me, yes, sorry about that. Public technology, right?
Right. So now we just need to go full screen and then get back to where you were.
So just mention about promoting mental wellness there, and then now upholding human rights, as I mentioned a while ago. That's very important for person to promote mental wellness. So the World Mental Health Day in 2022, they emphasize that mental health and well-being ought to be a global priority. And as I said before, one of the biggest challenges to this is really stigma and discrimination, and not challenge the lack of adequate investment in mental health services. The Lancet Commission in 2022, which is on stigma and discrimination reduction, here it was found that in survey results of persons with lived experience, that 80% of them thought that the stigma and discrimination they experienced towards mental illness affected them more negatively than the mental illness itself. And in the same survey, 71% of them felt the media caused more stigma and discrimination and caused that to be worse. And this by reinforcing negative stereotypes, for example, that persons who are mentally ill are tend to be dangerous, they are unable to function, and they are unpredictable. So in conclusion, this commission shows that stigma and discrimination in mental health infringes on persons' basic human rights and have negative consequences on persons' social exclusion and persons being productive. The second conclusion is that an effective way of decreasing stigma and discrimination is to allow persons with lived experiences, which we also call experts with lived experience, interact with those persons who don't have mental illness. Similar to what happened with persons with HIV/AIDS, which has caused some decrease in discrimination against HIV/AIDS. So we need to do our share in decreasing public stigma, because to allow persons who have mental illness to be able to recover. So we should avoid labeling them incorrectly. We should show respect for their human rights and dignity, protect their rights, uphold their rights, and try to exercise some of understanding and empathy when interacting with persons who are going through mental distress. Because it helps a whole lot in promoting mental recovery. So let us now look at promoting mental wellness in the workplace. And one of the important tools in doing that is employment assistance program. And this is usually sponsored by the organization. An objective of this employment assistance program is to promote mental wellness and to, as much as possible, mitigate against the onset of mental illness. It also works to alleviate issues that workers will face and the job situation, whether it's related to job or personal issues. It also, by doing this, help person to achieve optimal productivity. And of course, with increased productivity of individuals, then the organization will also improve its performance. So the impact of employee assistance program is that it decreases absenteeism, it lessens presenteeism, it also increases person's satisfaction, and person will stay longer in a job if they find that their mental well-being is considered favorably and facilitated through this program. Cause less person to be restive and cause industrial strike or sick outs. Of course, it causes less expenditure on medical expenses if persons can be identified early to have issues, treated effectively, and thus cause less cost to persons individually and to the organization. And ultimately, it increases the outcome and performance of the organization. In this staff of the employee assistance program, usually because of a psychologist or counseling psychologist who have a minimum practicum hours that is necessary for them to be a counseling psychologist. The person should not be connected to the organization and should be a part of a third-party independent service provider. So in this employment assistance program, person can get assistance through private consultation without asking anybody's assistance from the organization or supervisors, or recommended by a supervisor or manager who may have observed behaviors which show that person may need assistance from the employment assistance program. Information shared between employee and counselor is maintained on a confidential basis, so that the person would not fear disclosure to HR or to their bosses. I mentioned before, the employee of the EAP should not be part of the organization. And even though they're not part of the organization, it's allowed that you have anonymous monthly report, for example, getting service utilization, type of service being used, one of crisis interventions, which sometimes can also help the organization to improve its performance or development. So in conclusion then, EAP should be encouraged in organization for all employees to promote the mental well-being of the employees. And by doing that, will also improve the productivity of the organization. Now let's look at promotion of mental wellness in the community and what the Ministry of Health is doing in this regard. And here we're trying to strengthen the community mental health services by a program that's called Problem Management Plus. And the intervention program that seeks to use problem-solving approach to help persons to manage everyday issues and challenges. And to answer how we're trying to address this in a proactive way, the person may have issues and they may have pensive thoughts, but not be distressed, or they become long enough, they may have a bit of mental distress, they may become a bit unhappy, a bit anxious. I want to address these persons at this stage to state of no distress and having their problems, rather than allowing to escalate to where they either have mental health problems or mental health disorders. In which case, this person who are trained with PM Plus will refer these persons to mental health experts to address those situations. So basically, it's taking wellness to our communities to allow persons to have access to these services even before they have signs of mental problems or mental disorders. So in the first year of COVID-19 pandemic, global prevalence of anxiety and depression has increased by a massive 25%, according to scientific-based research by the World Health Organization. This brief also highlights that what has been affected most by this pandemic is because of lack of availability of mental health services, and that these services would have been affected even worse by the pandemic. So because of this increase in demand for services, there's concern that there may be persons who have heightened adverse challenges, who may not have reached threshold of having mental disorders or mental illnesses. And they may already know that a gap exists before where mental services are concerned. In our clinics, over 80% of our patients are psychotics, whereas we know that generally speaking in the community, there are more persons who have depression and anxiety. And also there's stigma attached to mental health services. So that's why we adopt this WHO PM Plus program, which give a community-based proactive approach to reduce persons' mental health needs and provide support for them, thus preventing them from having escalation of their symptoms of mental health disorder. So the essential component of this Problem Management Plus is a brief psychological intervention for adults using client-centered approach. These persons who are selected are not mental health workers, but are lay persons who have the aptitude to do this program. And in this program, persons are trained to provide 2 assessment sessions and intervention sessions once per week for 5 weeks. That's the kind of guidelines. And in these sessions are tend to be individual sessions, but it also allows for involvement of other concerned persons, whether it's family or friends, as the client wants or as the situation dictates. So in these Problem Management Plus sessions, we seek to address persons who may have fearful feelings of helplessness, and may have issues which may be due to situations in home or conflicts in the home, to enable those persons to deal with those problems. We do not train this person to diagnose mental health conditions, even though a person who may have some symptoms of being a bit sad or anxious. And importantly, when persons are seen by these PM Plus providers, we call them, and they have signs of psychiatric emergency like suicidal ideations or severe impairment due to their mental condition, then these persons are referred to the mental practitioners for intervention. So these lay persons are trained in information concerning mental disorders, so anxiety and depression. They learn about basic helping strategies. We practice these skills in role plays and also practice with clients. And they are supervised by a person who are, we call PM plus supervisors, who will be the ones who will consult, especially if they find a situation where they can't manage. Now, these are the persons who are trained in PM plus are persons from community-based organizations, so service clubs like Kiwanis and faith-based organizations. And all of these organizations, we have both the PM plus providers and the PM plus supervisors. Also, in these training, we try to encourage them to take care of themselves, because if they don't take care of themselves well, they will be able to assist persons in their communities. And the supervisors will discuss with the PM plus providers how their clients are progressing. We'll discuss difficult situations and how they can possibly manage those situations. We'll also assist them in things about role playing, tell them to practice their skills and assess their competency in different aspects of providing this PM plus provider intervention. And of course, we encourage that the provider take care of him or herself. This slide is just simply showing different communities in which we have PM plus providers who have been trained. This was taken sometime last year, so since that time we have had more persons trained, so almost all the island, all the parishes have PM plus providers. Our target has been about 250 beneficiaries within a period of about 6 months, but we are falling short for about 60. I think sometimes because of the new program, the uptake is a bit slow, but so far we have trained about 217 PM plus providers and 54 PM plus supervisors from over 20 organizations. Now let's look at mental wellness in the schools and how we can promote that. And one major program we have been instituted in the last couple of years is what we call School Mental Health Literacy Program. So in June 2020, in the height of COVID, there's a power training of School Mental Health Literacy Program. So done on a virtual platform under a 4-week program, which consists of 30 master trainers and 10 members from the mental health staff from the regional health authorities. And the mental health staff will provide supervision and resource persons for persons trained in the Mission of Education and Youth. So these master trainers were to then go on and train a group of teachers and go-to educators, especially health, life, and family educators, who were the main persons who were first earmarked to deliver this curriculum to grade 9 students. And regional schools are ideally placed to help individuals develop good mental literacy. Not only it will help the students themselves, but it will indirectly help the teachers, parents, and caregivers. And increased mental health literacy within the school system should help to decrease the number of inappropriate referrals, because it is now we get a lot of referrals from the schools, so much so we are overwhelmed and persons are getting like 3 months appointment, which we know is not adequate, but not against skin because of the overwhelming demand, it does cause a strain on us providing timely intervention sometimes. Also, during this program, the teachers who deliver the program should also be better aware of what are the behaviors that are considered to be normal behavior for the age of the child, and also what is a normal reaction to life events, and then to know what situations are outside of that realm and need referral from further mental health assessment. So this program formed the necessary foundation for mental health promotion, prevention, and care within our school system. It helps young people to gain the knowledge, attitude, competencies to help them to help themselves, and not only help themselves, but also help their peers, because sometimes they can help their peers much more than older persons within the school system. And this program consists of 4 interconnected components. Number 1, helping them to understand how to achieve and maintain good mental health. Number 2 is helping to understand common mental health conditions and what are their forms of treatments. 3, help them to where mental illness, like other illness, can affect anyone, and to try to decrease the stigma attached to mental illness, because you know that sometimes if kids know other kids have mental issues, they will tease them. So hopefully during this program, that stigma will decrease. it also helps them to know when and where to get help so they can access the help early. So this program has been supplemented by 60 school nurses which have been trained to facilitate the delivery of this program to grade 7 students from October of last year. And it will last for the next few months, and in June, when all the grade 7 students should be exposed to this program. As it should take about 8 to 12 hours, and hopefully during the summer of this year, we'll have a monitoring evaluation tool applied to see how effective this program is, how it can be improved to enhance its outcome. Our activities within the school sphere that we have implemented to improve mental health wellness is Do Your Share campaign, which basically is saying to persons, be willing to share your concerns, your issues with other persons, and to put that in the scope of a wellness bench, which speaks not only about mental wellness, but a holistic approach. As we know, that all aspects of health does affect mental health. So it's not all about mental health alone, but your physical health, your social health, your spiritual health is also important. We also produce 4 audiovisual toolkits, and these represent 4 aspects of health: social health, physical health, mental health, and spiritual health. And these are less than 10 minutes videos, which are presented as a springboard from which small group sessions can be held with students to discuss different aspects of health and how one can achieve good social health, good physical health, good spiritual health, and good mental health. And these are unveiling up one of those wellness benches that was unveiled at one of the schools in the Do Your Share campaign by the Minister of Health and other dignitaries. So in this slide, we see our mental health services, and you can see at the bottom is self-care. It's emphasizing that important part of mental wellness and achieve mental wellness is for a person to learn how to take care of themselves. So not only take care of the physical health, which is important, maintain good relationship with those around them, and also to be very confident about themselves and to, be number one fan of themselves. That's very important at the basis of promoting mental wellness. Then there's the informal community, which consists of caregivers, informal and formal caregivers. And above that comes the primary care mental services. And primary mental care services, I am pleased to announce, will involve family doctors. And in this process, we want to integrate mental health into primary care system. And it's very important, as I mentioned earlier, the big treatment gap, because we know that in our clinics, about 80% of our clients seen in our public clinics are suffering from psychotic conditions. But we know that maybe 1% of the population, whereas over 10% of the population may be suffering depression, and yet these persons are not seen in our clinics. So where are they seen? Hopefully they're seen privately, but I'm sure some are not seen at all. Also, this treatment gap also is because of the stigma attached to mental illness. The persons don't want to go to mental clinics because it's for persons who are very mild and they are not dressed and speaking in any way that is seen rational. So persons stay away from these clinics. Also, important thing to bear in mind that there are comorbidity between mental illness and non-communicable diseases, where let me show that persons who have chronic diseases are likely to have depression in about 30% of cases, which is above the general population, which is up to about 20% of the population may have depression. And then we did a mental investment case in Jamaica. We saw that early intervention of depression and anxiety, and to a lesser extent psychosis, will restore persons to a greater than 75,000 healthy life years to our population. So an important part of that process is primary and secondary care physicians, both private and public. And here what we are embarking on, which I've done before, but we using this World Health Organization Mental Health Gap Action Program, which consists of modules, which help to a person to understand how to diagnose, take a history, diagnose, and treat mental health conditions, and also know when it is that one to refer persons. And this program will roll out in the next couple of months within our public system. Hopefully some private doctors can be involved as well, and in diagnosing and treating persons early under the supervision and consultation with mental health practitioners. Then there's availability of external support, which is very important because sometimes external support can be accessed at a moment's notice when persons are in distress. So there is access to faith-based organizations like Family Life Ministries, True Life Internationals. There's a psychosocial support provision by Jamaica Red Cross, and the numbers are there. Then there's a 24-hour, 7 days per week mental health and suicide prevention helpline, which I know all of you on this call should know this number of 888-LIFE or 88639-5433. And for those persons who have substance abuse counseling needs, then there's a National Council on Drug Abuse helpline. Then there's also Rise Life Management Services, which also provide counseling for drug abuse, for gambling addiction, and for other mental health challenges a person may be having. Then there's a Human Chat line, which was recently introduced, which especially is a text line, particularly for youngsters who may have their own challenges and may not want to speak over the phone to anybody, but may want to text. They can text to this chat line and get responses from psychologists who will provide support for them. And then there's a safe spot for the younger ones who may want to access support. So in conclusion, promotion of mental wellness starts off with self-care, promoting self-care, encouraging persons to take care of themselves. It's also important that we also decrease stigma and discrimination, because this sometimes is a big barrier for a person to access services early. And hence the reason why we want to incorporate mental services within our primary care system, so persons can access these services without fear of stigma and discrimination which attach to going to mental clinics. Then it's important thing about promoting mental wellness to provide a supportive environment. Supportive environment in the workplace, in the schools, in our communities, and some of the interventions I mentioned earlier. And then, as I mentioned earlier, early detection and treatment is very fundamental. But the earlier persons are detected to have conditions and treatment instituted quickly, then chance of recovery is so much greater. And recovery model is what we're working towards. Not a situation where a person with mental ill, their symptoms are controlled with medication, but they're not functional. Because when that is happening, the person will have a clinical recovery, but not functional recovery. We want to aim towards functional recovery where a person who is mentally ill can be stabilized, no more symptoms, and can be functional. So a person will become mentally well by such effective treatment. So I'll close by saying thank you for your attention, and remember there is no good health without mental health. Thank you.
All right. Thank you, Dr. Goulbourne, for certainly sharing with us those initiatives that are being rolled out and currently being employed in the Jamaican landscape to promote mental wellness. We appreciate the effort being made to distinguish between mental illness and mental wellness, in the sense that being well doesn't mean that you cannot be ill, but really is really how do we optimize your functioning within that illness paradigm. We do have a few minutes based on my watch that we could take perhaps a question or two in the question and answer segment. But just wanted to highlight the three programs that you mentioned for home, work, and school, which is the Employee Assistance Program, and in the workplace, the Problem Management Plus initiatives that you're having in the community, and the Mental Health Literacy Program that you're rolling out in the school. So I did spot a question. I'm not sure you want to address it, about what is the monitoring and evaluation framework that you're going to be implementing to ensure or to assess the efficacies of these initiatives. So briefly, if you just want to just make a brief comment on that, that would be very helpful.
Yes, so we realize that in doing a program, we need to have some monitoring evaluation. We do have tools that we monitoring both qualitatively and quantitative or effective the intervention has been, and to ensure wherever it needs to be improved, it can be improved and modified. So yes, we do have monitoring evaluation tool that will be employed for all these programs.
Okay. Thank you so much, Dr. Goulbourne. I do encourage participants to use the Q&A component of the Zoom workspace application to pose your question. Dr. Goulbourne will proceed to answer those whilst the other presentations are ongoing. At this point in time, it's indeed my pleasure to welcome a presentation from the Heart Foundation. I'm not sure who's going to be presenting on behalf of the Heart Foundation, but I have on my program a presentation of the Heart Foundation.
There's no sound. So.
Yeah. Sam, there's no sound. While we rectify the technological glitch.
Now, on our screening, so the Heart Foundation of Jamaica was founded in 1971, over 50 years ago, with an aim to promote heart health through Jamaica. We do that through screening, advocacy, rehabilitation, and education. And we have two main parts. That is the medical services and emergency cardiac care. And these are the two parts that I'm just going to touch a little bit on today. Now, on our screening list, we have ECGs, regular ECGs, total cholesterol, blood sugar, hemoglobin, HbA1c, as well as cholesterol profile checks. All of these checks can be done via walk-in or with a referral from our lovely doctors. We also have more advanced diagnostic tests. All of these require referral, and the Heart Foundation of Jamaica does have referral pads that we distribute routinely. That would cover dobutamine, stress echocardiogram, stress tests, Holter monitor, ambulatory BP, and pacemaker evaluation. If it is that a patient requires these services, they just have to call us at 876-619-7007, 7008, or 926-4378 to make an appointment and come on with their referral. An appointment is quick and easy, our services are fast, our medical professionals are very friendly and very thorough. Nothing will be missed, the results will be ready in less than a week for the doctors to receive. I did also mention that we have emergency cardiac care training. That covers training in areas such as advanced cardiac life support or ACLS, pediatric advanced cardiac life support or PALS, ECG dysrhythmia training, as well as basic life support training. For all of these services, they're for medical professionals and they all come with requisite CME hours. I know a lot of doctors are like, okay, but how many CME hours do I get? For BLS, it's 6 CME hours. For ECG dysrhythmia, also 6. And then for PALS and ACLS, it's 15 CME hours. We are a certified training center of the American Heart Association. So the certificate that you'd get for that is valid for 2 years. It is internationally recognized, and you also get an AHA manual with the training done, and that is yours to keep. How do I go about booking this? Simple. You can call us at 876-619-7007 or 7008, or you can call 876-926-4378 or WhatsApp us at 876-334-4998. You can also send us an email, and that is info@heartfoundationja.org.
Did you know that many of my schoolmates have an unhealthy diet, especially at school? And now 23% of them are overweight and or obese? And so one less sugary drink at my school may mean one friend less, or 2 or 3, at risk of cavities or diabetes. And if we're served less foods high in saturated fats, sugar, and sodium, it may reduce our risk of obesity, heart disease, and high blood pressure. The solution is simple, right? Together, let's get unhealthy foods and beverages out of our schools.
A message from the Heart Foundation of Jamaica and partners.
I know I'm hungry. I'll take up these chips, yeah?
I them fruits I look on, but I find it, boy, look how much money for the banana. You want to take up chips? Now you say your doctor say you have high blood pressure.
So what wrong with the chips?
First of all, miss, turn around this and look around yourself at the nutrition facts. You see how much sodium in this? 3%, 60 milligrams. That's just 1 ounce. And how much? 10 ounces in the entire pack. So multiply the 10 by the 3. I know you're not going to eat the 1 ounce.
The whole bag for full my belly. Doctor never said nothing about sodium, so I don't know what you're talking about.
Aye, sodium, salt, the same thing. Look at this one over here, so see? You see them put 2 black octagons on the front, high in sodium and even worse, high in saturated fat. So double trouble that. So basically, these 2 black octagons, them sum up all of the information around here to tell you what is unhealthy about the product.
And sodium and salt, as you say, is the same thing. So this high in sodium, I can't take this one. I prefer the HFSS brand because it points out these labels and say I was going to take a juice, it's high in sugar.
Exactly, no bother. Say water over the cooler. Come, let's go.
The nutrition facts panel can be hard to understand, and as consumers, we need an easier way to translate what it is that we're consuming in our foods.
Front of package warning labels are clearly simple, visible graphics on the front of ultra-processed food products and beverages that can help us as consumers to know what is unhealthy about some food products. A recent study by the Pan American Health Organization, the Ministry of Health and Wellness Jamaica, and the University of Technology Jamaica showed that these black octagonal warning labels placed on the front of food packages and beverages are 9 times more effective in helping Jamaicans make more informed food choices.
Food sweet, but you know what you eat? Me glad the ox cause it not funny. Not funny. Me say help while you're more than money. If no fun healthy things in on the bag. Put a warning on the front label, not the back. Enough sugar where you add. Put it on the front label. Enough salt where you add. Put it on the front label. Only my fats where you add. Put it on the front label. We don't want search for the facts. We want the warning on the front of the pack. We don't want a heart attack. We want stay on track. Put it on the front label, not the back.
All right. Thank you, Heart Foundation of Jamaica, for bringing to our attention the importance of reading the labels, as well as reminding us of the wide range of services that are offered through the Heart Foundation of Jamaica. Diagnostic services, including training for healthcare professions. We now move to the next presentation, which will be done by Dr. Ganesh Shetty, a consultant psychiatrist. He will be speaking on the impact of new technology on mental health diseases. Briefly, Dr. Ganesh Shetty is a consultant child and adolescent psychiatrist who is employed by the Kingston Health Region, Kingston Health Department for the Ministry of Health and Wellness. He currently supervises the clinicians working at the Child Guidance Clinics at the Comprehensive Health Center and the Glen Vincent Health Center. He's well known within the Jamaican medical community for his work in adolescent psychiatry. It's indeed my pleasure on behalf of the Caribbean College of Family Physicians to welcome Dr. Shetty on his presentation this morning. Dr. Shetty, all yours.
Good morning, Professor Reed, and thanks for the introduction. And good morning, colleagues. And we are in a very interesting phase of our lives where we are in the information revolution age. And there's definitely something great and something not so great about it. And we're going to look at it quickly. So, impact of new technology on mental health diseases. I have this presentation put together with some technical support from Copy, that's Copilot, and Gemmy, that's Gemini, which are AI from Microsoft and Google respectively, as well as some slide courtesy from Dr. Judith Leiba, Director, Children's and Mental Health Services, and one of my younger colleagues at the Child Guidance Clinic, Dr. Davis. So let's try to understand the complex interplay between new technology and mental health, recognizing that there's good and bad in both. Benefits and risk. Let's identify specific mental health disorders that are most affected by technology overuse and addiction. Recognize warning sign of technology-related mental health struggles in our patients, including those related to social media, gaming, and pornography. Let's look at what strategies for screening, intervention, referral are there once it becomes problematic. And education is such a barrier against misinformation and addiction. This is teen on screens. And one of my colleagues said, we have a 5G generation now, not the bandwidth of the internet, which is provided lately, but he believes that our young people nowadays are not grateful, are greedy, take it for granted, goalless and godless. I would like to disagree with that, but in some cases it does look quite likely. So there's a good, bad, and ugly in everything. And here comes Dr. Jean Twenge. He's a psychology professor in San Diego State University, and she did a lot of whistleblowing and a lot of warning about what the technology is doing to young people. And she has been perpetual tick on the back of technology companies, which put profit first and everything else next. I still need to get used to those different terminology of different generations. But what she basically did is looked at national surveys of teens themselves. And it's a massive study with millions of kids involved and adults involved too, over last 50 years or so. And what she was noting and warning us about are young people are becoming disconnected with the majority, feel lonely and left out, and they're getting more depressed and with severe impairment, and they're losing confidence and self-esteem, losing that luster we see in young people. And there is increased suicide rate correlating with increased technology use. Smartphone particularly was looked at, and they're sleeping less and more unhappy. And this is what she had to say, that it's all good, it's all great, but an hour or two a day is better. And after that, you have to live your life outside the technology box. And you know about whistleblowers who went to Congress in the US and blamed, I think it was Facebook, now Meta, that they knowingly disregarded research to show that Instagram was killing girls by killing their self-esteem with all the images they get, which often are not even true. And so they joined the Surgeon General, who say that the burden of managing social media should not be just responsibility of parents and kids, but also to be more, regulated so that it is a fair fight between the governments and the companies, mega companies, which employ some talented engineers, designers, and even mental health professionals to make them addictive. These algorithms are so accurate that the companies know more about you and your kids than you yourself. That's dangerous. And did join the APA, the American Psychological Association Chief Science Officer, who was testifying as well. He did say that there are some positive things about the technology, but how it is used, how often it is used, and who it is being used by, and what results need to be something looked at, and also how does it really affect their social and academic and personal development, brain development, should looked at. As much as it was a great boon during COVID, particularly when school was closed and everybody else stuck in the house, it was the only way young people could contact and communicate and connect with their friends and family. In fact, I could use the WhatsApp video and talk to my 91-year-old mom who is bedridden this morning. And with the technology itself, after I finish this presentation, I could have an online session with a patient I have in India. But at the same time, it can promote maladaptive behavior. Some behaviors which are glorified put there without any filter can have a copycat influence, and cutters and cutting is one of them. Young people have this deliberate self-harm, non-suicidal self-injury, and that also is an issue where comparison takes place, and that is not good for young people's self-esteem. There can be a lot of influence, which could be positive and negative online, and that is definitely not healthy when it keeps your teen up in the night. Sometimes it could be so pervasive and influential. Media can be quite impressive in its appeal and its impact on your brain, so that it can even change conscious, where some almost pornographic way of capturing everything on your phone, instead of knowing what's going on and doing something about it. So you might have gotten a lot of video clips on your phone, which are disturbing. Kids doing bad things to other kids, teachers beating up kids, students beating up teachers in the school, and so on. And it does have some value in that there's evidence of what really went down. But just thinking about what was in the mind of the person who was taking this video, was it just to have an evidence which can be used to bring justice, or was it like, I'll take this video and put it online and everybody can look at it and enjoy, maybe? That is worrying. So the advice was, let them know what it's good for, what is not good for, and parents communicating with their children, teaching them what exactly these companies, these apps, these platforms online are up to, and how they can use them and not being used, was the message. And here we need to look at internet addiction children. I just quickly quote two examples. Two kids, one was primary school and one high school. The primary school kid was found doing something on the internet at 1 a.m. and the mother went and tried to grab the tablet from his hand, and he instinctively turned around and tried to squeeze her throat. Maybe he was trying to kill something on the video game on which he was playing, and probably mistook his mother for one of the ghouls he was supposed to kill. But she got away by kicking him at the right spot. And there's another child whose father got fed up of he being online all the time and disconnected the internet. And this teenager got up and took some sanitizer, which was to sanitize your hand against COVID virus at the time, and just throw it on his father's face. It's almost like somebody who is doing alcohol or coke and addicted to it, when being grabbed from them, is going to interact or react violently. So at the same time, we could not have this presentation without help of technology. And it is a fact that children ages 8 to 10 spend 6 hours a day on screen, and children 11 to 14, 9 hours, according to one of these studies, and 15 to 18 spend 7 hours. That's a lot of time. I don't know when they get time to go to school and do any school work. And in Jamaica, the study on 2022 looked at the access to internet was 68.2, which was essential during COVID time. In fact, the problem then was a lot of kids were left out without access to internet, which would be access to school and learning at that time. But looking at the problem internet use, the prevalence is different in different places, and based on which research you're looking at. But 4 to 25% of persons in different countries might have some problem with screen addiction. And interestingly, it is more in Asian countries. And still trying to define. There's internet addiction, there's social media addiction, there's phone addiction, but the fact to be appreciated is the addictive nature of internet, and more use, more research need to be done, but there's not much consensus. So today, internet gaming disorder has made its way into the medical diagnostic lexicon, DSM-5, as a proposed disorder. And at least 5 of these symptoms for 12 months is necessary for that, which is preoccupation with the gaming, withdrawal symptoms when it is not allowed. They get tolerant, so they need more and more to get the same kick, more hours spent, unsuccessful attempts to reduce or quit gaming, lots of interest in other things, and they continue to do excessive indulgence in gaming in spite of it causing academic, occupational, relational problems. And there's a sense of deception. There's this young man who would go to bed or pretend to go to bed just before his parents will go to bed, and he'll get up and play games all night and go back to bed just before his parents will wake up in the morning, giving an impression that he was sleeping right through in the night. And of course, he will sleep right through the day in the school, except during lunchtime, and he'll slip out and go to a gaming place nearby and play game. And that also could be an issue where it is used to deal with your anxiety or depression or alienation or some other thing. And of course, it will cause significant occupational, academic, and relational problem. So this sounds very much like any definition of any other substance use disorder. And impulse control is a big part of it. There's urge or craving prior to initiating the behavior. There is decreased anxiety, positive mood when they indulge in it. And over time, there's tolerance, and there's dysphoria when you're not allowed. And it does get into your brain literally in terms of changing the neurobiology of your brain. And there's some evidence in terms of what the screen does to your brain. Now, what about children and with mental health issues and internet? The correlation may not be causative, but there's definitely some connection, association between problematic internet use and presence of one or more mental health issues. Like depression, anxiety is common, comes behind that aggression, ADHD, autism spectrum disorder, OCD, and psychotic disorders. All these things have one thing in common: they make it hard for a young person to communicate, relate, and deal with everyday challenges when they're going through any of these conditions. And of course, these conditions and the internet use, which could be associated with it, could cause problem, how they learn, how they connect, how they behave. Now, there could be some physical impairments also. The young man I mentioned about being up in the night playing and sleeping in the day, he will become so fat, obese, in fact. His fitness was challenged even when he's asked to take the garbage from kitchen to the place of disposal. He'll get short of breath. And of course, you don't sleep well in the night. It's not a good thing for your brain. Eyes are impacted, headache, clicking can affect your carpal tunnel. And they lose out. They lose out on opportunity to learn, opportunity to connect, have friends. And many times there's a lot of deception going on in terms of how they quickly change the screen from what they say they'll be using for homework or research to actually playing a game on the side. And in fact, I remember one of the young fellow, he was just 8 years old. It was COVID time, and I was having online session with him, and I saw the young man's eyes moving very rapidly around the screen, and I asked his mother to check his screen for history. Actually, the guy was playing game when he's supposed to be having a session with me. And these are some tools which can be used to see if the internet use is problematic, as actually is addictive or addiction has been taking place. And these are some recommendations. They're not written in stone, and I think we need to use the culture and situation in Jamaica to decide what is better options for us. In that our kids get traditionally a lot of homework, and can we afford to give them so much time on the screen every day so that they could do all this and also do their homework, which is necessary. And we need to look at even the amount of homework they get is rational or not. So no tablet for anybody less than 2 years unless they are sick and the doctor has prescribed some tablet. Unless they're 2 and doctors have prescribed them some tablets, they can't get any tablet. 2 to 6, 1 hour, 6 to 10, 2 hours, 10 to 18, 2 hours. But again, should be supervised in the primary schoolers and should be encouraged for independent, healthy use. But that has some kind of idea what sites they're accessing and what influence they're succumbing to sometimes. And we need to mingle online, offline activities, and it's not enough to play FIFA online, but also play football outside. These are some treatment models which are being developed. One is CBT for internet addiction. Basically, it's about finding out what triggers these urges and behaviors, what is the function of these behaviors, and what can be done to alleviate what is triggering them, and how we can help them to control the impulse and overcome their addiction. So how are we doing time? Okay. And when it comes to parents, then they have to start making their children smart about internet and about technology, and make them know that when there is anything which is untoward, they could trust their parents to disclose that, whether they're being bullied or they've been introduced to some unhealthy site. And same Dr. Google can do it. For example, a child was asked to write 1 page on pen, and she asked Dr. Google for some information by putting in the search PEN, and what came up was PENIS. And the 6-year-old was curious and she ticked it, and it took her to porn site. And of course, she was curious about what these adults are doing to each other, till our mother caught her watching porn and brought her to me. So these folks online, they only business with business and not your child and what is healthy for your child. So you have to have whatever technology on the phone, on the tablets, and you have to decide how much access they have to that. And there are so many apps and programs which can help you to monitor that. For example, Family Link is one which is used, and there might be other which are more efficient. And I like Family Link because one of my colleagues had warned her child who was on a vacation somewhere else not to go on adult, he was about 10, I guess, adult YouTube site. It's supposed to go only kids YouTube. And the guy got curious and went on adult YouTube site, and mom got a ring on her phone. She could immediately call him and say, come off the adult YouTube site now, right? So technology can help to deal with problems arising from technology too. So communication is basically crux of any parenting or any connection for that matter, and make him know that we are not going to judge them, reprimand them, punish them, and just allowing them to express themselves along with any fear, any problem. And even if they're wrong, they should have a trust that you'll be fair and still helpful and still love them, right? And some recommendation is what to say, being mindful, knowing that you're online for whatever period of time, because minutes turn into hours, and some timers or apps can help you to regulate the time you spend. And again, to decrease the comparison which takes place online, you need to bring them up to speed with what exactly happens. Most of the stuff is all what folks want you to see, usually the good side of themselves, and sometimes curated and photoshopped and so on. So what you think is what might be the case. And just because they look good doesn't mean that they're feeling good or having a good time or good life, right? All right. So, and also you need to know that there are a lot of fake Insta account. I recall this girl from country was lured to be friend from a girl from town. And one time, the country client of mine was in her teens, happened to come to town, and she said to her girlfriend online in town, "Hey, I'm coming to town. Can we meet at one of these food places, supermarket complex?" So why not? And then it turned out it was not a female, it was a male who kidnapped her. And I don't want to go into details of what happened afterwards. So there are a lot of trappings by the technology and the people, the predators who use technologies to lure your young kids into doing some things which are very harmful. So stage is set for all of us, family physicians, particularly in this meeting. And, you know, mental health disorders are on rise globally. COVID kind of opened the lid on the pot. And technology is a genie which is out of the bottle, you can't put it back. So we have to find a way to use it and not be abused by it. And of course, the interplay between technology and mental health can be positive and negative based on what is it. For example, what are the benefits? I could not do hundreds of sessions of teletherapy if we did not have technology. And if we did not have telemental health in the child guidance clinic, which was used to have up to 90% of the sessions during COVID safely and effectively, we would have not been able to provide service to a lot of kids who needed it through the child guidance clinic, KSA Health Department, as well as elsewhere, I guess. And online support groups can be quite helpful for the alienated and lonely who feel nobody's out there for them. And mental health apps can not only help you to know what is happening with your mental health, what symptoms you might have which need to be sorted out, but sometimes maybe OGless internet users might self-diagnose, and it's your responsibility to dispel what is a disorder and what is just a temporary state of mind, whether it's sadness or nervousness. And some mental health apps like eMoods, for example, will help you to monitor your symptoms and remind you of your medication and so on. And social media can be used to communicate and connect. In fact, I could not only see and talk to my elderly mom and family in India, but also check on them and see if they're doing okay. And I would not imagine if we didn't have internet or even the WhatsApp, how that would go. We celebrate birthdays and anniversaries online. We could have party on both sides. That's fun. And a lot of information, good information, good resources are out there, which makes access to information so easy. It's information age, and information overload can be an issue too. Comparison can be a killer to some teenagers who already struggle with depression, low self-esteem. Cyberbullying is a real thing. It's very sad because it's hard to be controlled. And when one of my clients was trying to cyberbully me, not purposefully, but because he was manic and he was putting all sort of things about me and other folks at university, child guidance clinic. When I consulted the police, they said all I can do is to just sue him. And here is this patient whose parents don't have much to do with him, and they're not even here in Jamaica. And all I could do is make sure that he gets treated, admitted and treated. And of course, he came back out better and apologized and all that. But unfortunately, his friends who did not know that he is sick at the time and what he's putting out there is not true, we're tempted to believe. And that's the thing, folks, we need to guard ourselves. We have a tendency to believe bad things about people first, then we have reluctance to believe good things. And that can be explained by brain morphology, in that we have a survival center, and we need to know where the bad folks and bad things are so we can protect ourselves. So I would not blame anybody for doing that, but we need to be mindful how brain works and try to be vigilant that we don't fall for believing every lie which is put out there by everybody, about everybody. And of course, got to be aware of digital devils. And digital deluge is a term used for the flooding of information which is out there. And if you're not careful, it can drown you. So we need to be very selective in what WhatsApp groups we subscribe to, what sites we subscribe to. And also we need to be aware of digital deception. A lot of lies are outside. A lot of people are trying to sell their lies and their products to you. And sometimes it could be even very immediate. Like other day I was in the country and somebody sent my wife's friend a video of landslide in St. Mary. And she immediately panicked and called me and said, hope you're not on the road, because it's a big landslide. I don't want to get caught up with it. And when I checked, that video was true, but not something which happened that day. It had happened years ago. So you can get this. And now I'm told that with AI, if somebody can record my voice right now, they could use some AI online and put something else which I never spoke to my image and make it look like I'm speaking it. So you might see Dr. Shetty online talking some foolishness. Don't trust it. Only if you're in my office and you see me talking to you and my voice is projected at you and my lips are moving, trust that, and don't trust anything else online about unless you have proof that that's true. And digital distraction. There are so many pings and things and notifications which keep going off all the time if you don't mute them. And you can look at this three young ladies here. They are in their bed with their smartphone, and instead of trying to talk and connect, and it looks like a daytime also from the light in the window, they are connect with somebody out there. And this was probably a situation where they're supposed to have met during Christmas. So digital disconnection, folks. And digital dementia is if you keep using your phone for everything, calculator on your phone for everything, there is a possibility you might forget what is 8 times 7 or 9 times 3. And if you use Lady on Google to guide you all the time, you might forget your way to your office after some time. Because if you don't use it, brain is like a muscle, you lose it. And digital deduction, there's a lot of articles about different scientific studies and so on, but there might be some folks with their vested interests who might cherry pick some studies and support whatever they're trying to sell. And if you just focus on what account that particular company puts out, you might deduce something which may not be close to reality. So you have to spread your net wide and look at what is being mentioned and who is mentioning it and for what purpose. Like we do for any scientific articles, either a digital deception, there's, as I said, you might see Dr. Shetty talking foolishness online, but it is just because somebody captured my voice and my image today and fed it to AI and make it say whatever they wanted me to say. It sounds exactly like me, maybe a little machinistic, but yeah. So definitely there's a connection between technology overuse and depression, anxiety. Sometimes it could be they're trying to cheer themselves up to go and listen to some music. They're trying to deal with their social anxiety by connecting with people online, but it could be also leading to more disconnection, more alienation, and more depression and anxiety. Definitely blue light is not good for sleep, and so is playing games in the night. ADHD is a neuropsychiatric disorder which makes it difficult for the child to focus on one thing and stay on one place for long, and they thrive on constant stimulation. And what else can provide it than variety of entertainments and games online? Body image anxiety can be triggered big time by the pictures your friends post on Instagram, and this fear of missing out, they talk about, which is the abbreviation is FOMO, fear of missing out. You see what people are doing there. Oh, I'm not doing that, so I may not be good enough. And the antidote for that is JOMO, that is joy of missing out. Sometimes you're better off without doing what your friends might be doing, and you might like to do something more fun, more joyous than following the copycat. So what you could do to help identify if there are any technology-related mental health struggles. Open conversation safely, non-judgmentally about the digital habit. I don't know if you have an intake. I don't know if you want to add a couple questions about their digital habits, and helping patient and parents, what are the healthy limits, and referral when you know that this is something which would need mental health specialists. Education, education, and education. And some proactive strategies would be setting boundaries for kids and scheduling tech-free time, and children being encouraged to deposit their gadgets to parents, and having a dark room to sleep and bed only to sleep and nothing else will be helpful. And kids are very smart. If you don't make that rule, they will say, okay, I'm not able to sleep, so I need to listen to some soothing music. But then they might be doing something else instead of listening to soothing music and be up all night. And real world connection, real world relationships are encouraged, and not to hesitate to check out if it needs more help. And this traction and addiction is not restricted to kids. I have a client, is a retired guy who came to me. He used to teach retired teacher, and said, Dr. Shetty, you need to save my marriage. And I met the elderly lady, his wife of, I don't know, 40 years. And I was wondering what happened. She looks a little not too young to give this retired teacher a bun or anything. What's going on? And it turned out that she was addicted to Facebook. Although being a Christian family, she was just logging into some Christian praises and other videos on YouTube. Nothing unchristian about it, but she had just tuned off and turned off anytime to her husband, and the husband will be in his bed waiting for his wife to come, and she'll be checking on some praise service done in New York by her favorite group. So nobody's free of temptation, and these companies employ some really talented engineers and behavior specialists to make it more addictive. So embrace technology, but protect mental health. It's not a replacement for human connection. We can harness its benefit by mitigating its risk. Family physicians are in front lines of everything physical and mental. So I'm begging you to do your part by educating and empowering patients and parents so that we can navigate this rapidly evolving digital world, maintaining our sanity. So let's quickly look at a couple things which are specific. Gaming disorder, which has been recognized by WHO. Same kind of things, can't control. Gaming become more important than anything else, and negative consequences. And 1 out of 25 adolescents could be affected by it. And of course, you know the problems, isolation, academic, relational, and other issues which can be affected. And what are the warning signs? Just like any addiction, they lose interest in hobbies, their academic performance plummets, they withdraw socially, they're miserable and aggressive when you stop them or cut the internet, and they become anxious when they're losing, depressed when they're lost. And of course, physical symptoms, they put on weight, their head and eye problems, and they are into themselves, into their game world, and out of, they're in your house, but they're not in your house. Okay, so sooner you address it, better it is. CBT can help, family therapy can help. Sometimes kids might be escaping into these things because they can't take the bickering between the parents, for example, or annoying from the siblings and so on. So we need to look at the whole picture, not single out child as a problem, because it could be the family, it could be the system, it could be the school, which is a problem. And medication can help to deal with underlying disorders. Clear limits, boundaries, talking openly, monitoring their gaming habits, seeking help is all helpful. Another one is phone addiction. Pornography and mental health is a complex
relationship. Hey, Dr. Shetty, 1 minute left.
Okay, great. So there's compulsive sexual behavior disorder, which is recognized, which is a result of porn addiction. And the brain looks exactly like when other kinds of addiction are taking place. Getting treatment, making your office more supportive and non-judgmental would even help these folks to even talk about it. And I know of many teenagers as young as 10 who are addicted to porn, and there are some more destructive kind of porns I was informed, like gory porn, where somebody kills somebody at the end of sexual act. There are a lot of stuff happening there, guys, and we need to be one step ahead, or else we'll lose our kids, our young people, and ourselves if we're not careful. Thank you.
Thank you, Dr. Shetty. Thank you for carrying us through the issues related to the technology. It is indeed a benefit, but with every activity, really. There's the risk-benefit ratio that we are always faced with. As family physician, you have encouraged us to have open conversations with our patients, try and identify what their patterns are, and really to work with parents to limit or regulate screen time, and to educate ourselves and our patients about the technology, the impact it can have, and the benefits it can have. So thanks for sharing these very sage thoughts with us. We do have a few minutes based on my thing here. We could take perhaps one question or so. In general, the recommendation is that we use the question and action module of the Zoom workspace. You type the questions in there, and Dr. Shetty will be able to respond to those questions even while the other presentations are ongoing. So are there any burning, let me see here, questions?
I think all the questions in the Q&A were answered, actually.
Right, because they were from the previous presentations. All right. We are seeing, certainly I'm seeing on my program here that there are some poll questions that you have in the bag, Sam.
Hey, Doc. Yeah, I actually didn't receive any poll questions. I saw it on the program as well.
All right, fantastic. All right, so we will just focus this particular section here. Are there any specific questions? I saw a hand being raised. What we would prefer if they type the question in the Q&A module for Dr. Shetty to respond.
Agreed. But if anybody would like to raise their hand to speak, we could allow that at the same time, so we could have discourse. If anyone would like to, you can raise your hand as well.
All right, just scanning the menu system here. I'm not seeing anything just yet. Whilst you can do that for me in the background, Sam, I just wanted to ask Dr. Shetty if he has a sense. So we know that the Psychiatric Association has labeled some of these excessive behavior or addictive behaviors as mental health disease. Does he have a sense of what the prevalence are? So, for example, the gaming disorder or the sexual addiction on technology. Does he have a sense of what the prevalence is like in the Jamaican context?
I don't have access to of any Jamaican studies, but elsewhere the gaming disorder can be as prevalent in adolescent and young adults as much as 3 to 4%. So 1 in 33 to 1 in 25 folks we might have around us might be addicted, young adults and teenagers.
Okay, fine. And in terms of relative ranking, if you were to look at it as a full menu of mental health issues that an adolescent psychiatry faces, how would you rank it? Is it in the top 5? Is it in the bottom 5? Do you have a sense?
It would be in terms of different level of overuse. It could be in the top 10. But in terms of meeting all the criteria for internet addiction, which are quite stringent, we are not, because it's always associated with something as a mechanism to cope with some other disorder. Like, for example, if you're anxious, socially anxious, you would like to connect with folks online instead of face to face. And if you're depressed, you're trying to cheer yourself to listen to a lot of music, and that becomes addiction. So in terms of pure addiction, internet is mostly when it comes to gaming addiction. So it's still not in the top 5 for sure, but it's always comorbid. We are hardly seen any pure addiction, and there's nothing else. There's no family turmoil, there's no depression, there's no anxiety. This always comes in a context, like many other disorders, like even substance use. When you dig deeper in the history of an alcoholic, there's a lot of anxiety going. So they're trying to self-medicate to deal with the anxiety. Yes.
Sure. And I have two follow-up questions. So Dr. Goulbourne, in his previous presentation, spoke about the integration of mental health services as part of the primary healthcare offerings. In that integration of sets of activities, you did share with us in this slide in your presentation here, a few screening tools that we could use to ascertain whether or not our clients were at risk of, gaming disorder and so on like that. Is it part or parcel of the policy of the Ministry of Health to include those screening tools in the primary care setting to allow us to get what I considered to much a better view or better indication of the breadth of the problem?
Dr. Goulbourne is around. He could answer that.
Okay. All right. And then whilst we find Dr. Goulbourne to see if he could answer that question, are there any individual characteristics of persons that make them more susceptible to transition from doing mental game as a hobby versus moving them towards mental gaming as of more of an addiction? Are there any personal attributes that we could look at or
Yeah,
have been looked at?
definitely. These are the folks who are into all or nothing. If they get onto something, they'll get onto something. If they get onto football, they'll be playing football all the time for 6 months, and then probably they want to move on to badminton. And that's the personality profile of being intense and quite involved in whatever they do till they get tuned on. But there are some general characteristics which make them more susceptible. For example, low self-esteem and social skill deficits and social anxiety. Anxiety and depression as general. And these folks who cannot connect face to face, have problem connecting and still want to be a part of the group, or they want to escape into where they can be accepted by online group, and online gamers can provide that, as well as those who have been burdened by the academic pressure, uh, family turmoil, trauma. They are trying to self-soothe, find someone new to cheer themselves up, or escape from whatever is bothering them. And they could be more susceptible to getting into it. And once you get into, like any drug, you might do it as self-help, in self-medication, but then that becomes addiction because the genuine nature of those substances, and in this case, they are getting better and making it more and more addictive. Like TikTok has done a good job in getting so many folks hooked onto it because they've used what is the duration of attention span kids can, get into and so on. So there's a lot of behavior science goes into making of these platforms. And of course, that's why they make millions of dollars.
Sure. And my final question along this line has to do from the perspective as an educator. We're often asked to transition a lot of our didactic instruction using this whole concept of gamification, where we make games of some of our educational concept and content. Do children like these or adults like these learn better using the gamification, or it's an independent process in the brain, so it doesn't really matter?
No, actually, many of these games and so on are popular because of that. They incentivize and gamify. It's fun to do it, and every time you get a positive feedback, you hit a level, you go to the next level, and that is self-reinforcing. And I tell the parents, if you want the child to do something, you have to do better. You have to incentivize what you want them to do. You want to reward them for little stuff they do for you, and you need to make it fun, make it benefit. And that's why our teachers have a hard time because they are made to continue to live in the chalk and talk, where these kids are into iPad and tablets, and all the wonderful things it offers. So they lose every time. Only the most determined and committed will continue to pay attention in the classroom in days to come, I guess.
Yes, we're facing that at the tertiary level as well. But thank you so much, Dr. Shetty. Just to remind the audience that you can feel free to interact with Dr. Shetty using the question and answer module of the Zoom Workplace platform. We will now move to the other item on our program. So our webinars are not possible without the kind support that we receive from our sponsors. And within that context, I would just like to welcome as a partner in this webinar proceeding, Partners Health and Dr. Elliott, who is a stakeholder in the Partners Intervention Health Solutions in Jamaica, will be presenting for us for a few minutes. Dr. Victor Elliott, your time.
Hi, I am Dr. Victor Elliott. I'm an interventional cardiologist and I have been practicing for over 16 years, which means I've had experience in doing thousands of angiograms, angioplasty and stenting. And I have seen all sorts of complications and problems which can occur. I am one of the cardiologists and the director of Partners Heart and Health. And our goal is to provide the utmost care and the best cardiac care for our Jamaican citizens and anybody else who wants to fly in and to benefit from our resources. Partners Heart and Health is a cardiovascular center which has been using new and innovational technology in providing care for our patients' health. Some of this technology which we have introduced include cryoablation therapy for atrial fibrillation, ASD and PFO closures, transcutaneous aortic valve insertion, and the use of intravascular ultrasound IVUS for better imaging for our patients undergoing coronary angiography and stenting. So for this feature, we are going to focus on the benefits of intravascular ultrasound, IVUS, and its use in improving the care of the patients who undergo coronary angiography and stenting. So IVUS, as the name says, intravascular ultrasound, involves passing an ultrasound probe into the blood vessels to get a better image of the blood vessels. So while an angiogram will give you an image from outside in, the IVUS gives you an image from inside out. And as a result, we get a lot more detail about the blood vessel. We can actually see and measure the size. We can measure the size of any plaque, thickness, see how much stenosis there is, if there's calcium and the extent of calcification, and hence the better way to treat these vessels than what an angiogram would normally give us. IVUS is different from a plain angiogram in that an angiogram just involves injecting the dye or contrast into the vessel so you can get an outline of the vessel. It really does not tell you the actual size of the vessel. It does not tell you, is the vessel calcified? It does not tell you how tight the stenosis is. With intravascular ultrasound, we can answer those questions. So your doctor is no longer guessing, what size vessel is this? What size stent do I need? He can measure it and get an accurate account as to what needs to be done. And this is not just for the numbers. There are many studies which have shown there is improved outcome for the patients who undergo IVUS. There's decreased mortality. There is decreased redoing or to redo the procedure. There's decreased incidence of in-stent restenosis, and so the outcome for the patients are so much better. It is so much so that the American College of Cardiology, as well as the European Society of Cardiology, has indicated that IVUS should be used basically for almost all coronary angiogram procedures. Now, doing IVUS requires no further preparation for the patient than for when they go to do a coronary angiogram. As per se for a coronary angiogram, we will ask the patient to not eat a couple hours before, make sure they walk with their medication. They would have done blood studies prior, but they just come to get the procedure done. And as they will do the angiogram, if we do believe that IVUS is indicated, that is, if we believe there is a possibility of a stenosis in the vessel, then we will just, along with doing the angiogram, just pass the IVUS probe into the vessel to get the details that we know will make a difference in the outcome of the patient. When we're doing a typical angiogram, it involves injecting an iodine-based contrast, which for some patients can put a lot of, let's say, stress on the kidneys, and hence can worsen kidney function if you already have some form of kidney or renal impairment. For those patients, it is vital that we do what we call a low contrast study. And what is more low contrast than the intravascular ultrasound? You actually don't need contrast to do the intravascular ultrasound. So those patients with especially grade 4 and grade 5 renal impairment can undergo this assessment with very little contrast being used, and hence no threat to their kidneys or worsening of their renal function. As a matter of fact, in some centers, they can do a whole study, including putting in stents without using more than, say, 3 cc's of contrast. IVUS does make a difference, especially for these patients. And us at Partners Heart and Health, we have done studies similarly to this and have preserved patients' kidney function. I recommend IVUS because it makes a difference. It has made a difference for me as an interventional cardiologist in assessing the vessels that I'm working on. It has made a difference in that I can predict problems that could occur, and hence to have the right tools to make sure I can open up that blocked vessel. It makes a difference in that patients are coming less often to have another procedure done. And it makes a difference, most importantly, in reducing mortality. Improving patients' lifespan is the goal of what we do. And so as an interventional cardiologist, I recommend that if you're like the ACC and like the ESC, if you're going to be doing a coronary angiogram and possibly angioplasty and stenting, IVUS should be a part of that procedure.
All right, thank you so much for that video presentation. Dr. Elliott, do you want to continue?
Yes, I just have a short presentation just to add to that. And I just want to thank you all. And it's a good conference so far. I've been attending and listening in. So I just want to point out Partners Heart and Health, which is actually what was formerly known as PICJ, Partners Interventional Center of Jamaica. We have just renamed so that we can connect more with the audience, that we are a heart center, while you as physicians may understand what intervention would mean. We do a wide scale number of procedures, which as listed here, not just cardiac consultations, angiograms, as you heard, but just to point out, we do acute cardiac monitoring. So as some of you have done, you have a patient comes in the office tachycardic, you can send to us. We see them, slow down their heart, monitor them. If they're in acute heart failure, we can see them and start treating them instead of waiting in the long time in the emergency unit of some of our hospitals where you get through faster. And as you heard, some of the different procedures and listed there, of which I just want to point out in less than a minute, just a couple of them, including the cryoablation and a bit more. We do have a stroke program which we are working on. We have thrombolyzed patients who come within the first 4 hours of an ischemic stroke, and we have done this with the help of Medical Associates Hospital. And we do encourage you, if you have a patient who you think is having a stroke, send them to us or to the emergency unit at Medical Associates Hospital. And if they are a candidate, they can be treated, and the difference is dramatic. I could spend all day talking about this. But also, if they've had a stroke, we need to find out why they had a stroke, and we can do different investigations as listed to try and see why they had that stroke. including assessment for atrial fibrillation, which is a cause of 20% of all stroke. And we do have treatment for atrial fibrillation. If they have paroxysmal AFib, we can ablate and cure their atrial fibrillation. And this is for persons with paroxysmal or persistent but not permanent. And especially if they have heart failure, ablation is a class 1 indication for treating atrial fibrillation in these patients. We use what we call cryoablation, meaning cold ablation, but you can talk with us more to find out about the procedure. But your patients with paroxysmal atrial fib, refer them. We can treat them. We heard about IVUS, and I just wanted to emphasize that the European Society of Cardiology has pointed out from the studies, imaging of the vessel during an angiogram makes a difference. And you see the percentages there right in front of you. So you're talking about a reduction in death, MI, revascularization. And so it is so much so that the ACC, the American College of Cardiology, urges all interventional cardiologists to use some form of imaging when doing angioplasty and stenting. PICJ, or Partners Heart and Health, is the only lab in Jamaica and one of few in the Caribbean which is using imaging to enhance the studies. So why trust your patient to anyone else? We are following the guidelines. We are putting into place that which the European, the Indian Cardiac Society, the American College of Cardiology, and worldwide, they are advocating using IVUS. Let us take care of your patients and make a difference. Let us be your partners for life. And look out for the date, July 7th. We're continuing our webinar, our Where Cardiology Meet webinar. Some of you were in Where Cardiology Meet Pulmonology, and this year we're going to be doing Where Cardiology Meets Infectious Diseases, looking on updates on infective endocarditis, myocarditis, especially where we are today and what we know about cardiac COVID, myocarditis, and other topics. So save the date, you will hear more. Thank you very much.
Thank you, Dr. Elliott. And indeed, that's a very useful webinar, I anticipate, especially as there's still some concern about the effects of COVID on the heart and the effect of the vaccines, especially mRNA vaccines on myocardial function. So that would be rather interesting. Thanks so much. All right, colleagues, we're moving as scheduled in our presentation or webinar. And this morning, we are pleased to welcome Dr. Garth Rattray, family physician, and an honoree from last night who received the signature award from the World Family Doctor group, planning group, for his work and contribution to family medicine and health in Jamaica, broadly speaking. Dr. Garth Rattray, as we all know, is a family physician of many years, and he has a giant portfolio of public health service. He's going to be speaking to us on exploring the rise of mental health disease post-COVID-19. What is the role of family physicians? So without any further ado, let me welcome Dr. Garth Rattray for his presentation.
Thanks for the introduction. Let me start this. Okay, so that's the topic, and this is me. Some years ago, in 1965, a film came out called The Sound of Music, and the song in it, the Do-Re-Mi song, became very popular, and it began by saying, "Let's start from the very beginning, a very good place to start." And so this whole thing, the genesis of it, starting from the very beginning, when this terrible thing, COVID, came upon us. Well, it began in Wuhan, as you know, 2019, December. And right away, it was very stressful because we were told it started in this wet market where they were selling pangolins. It's illegal, but you know, pangolins are not what you think they are. They're not cute. they are actually called scaly anteaters, and they don't have teeth to chew their food. They swallow pieces of food and then they swallow stones and pebbles, and the stomach uses those to crush the food. Very interesting. But most of all, they can put out a scent just like a skunk. So I wonder if people want to eat something like that. But they eat them, and then they were saying, oh, it's a zoonotic virus. But then also in Wuhan, there is this place where they actually are doing viral experiments. So people weren't sure if the experiment escaped. But whatever it is, the point is that it caused stress and anxiety for many of us. Our thing started in March of 2010. The lady came from England, as you know. She went to a funeral, and we got our first case of COVID on the island. Well, as you can see, even the word, the COVID word, the virus, the first thing you see is a severe acute respiratory syndrome. Severe in everybody was, again, I mentioned this because it tells you what happens after COVID, quote unquote, after COVID. Very stressful to hear severe. We all know about colds and flus, and we get accustomed to those. But when you compare a flu in your mind to COVID, this is big, awful tiger that can tear the shreds, and you don't know who's going to attack. So right away, stress and anxiety was very common. And as I say, when they worked it out, about half of the people who got COVID were asymptomatic, a little over a third were mild, and 40.2% moderate to severe. If you had one or more NCDs, you had a worse outcome. And many of us have NCD. Many of us don't know we have NCDs. And all they get, more we have NCDs. So the older people that were at risk, as you see there about the percentages, the thing is that if you are over 65, you're at greater risk by 97 times than anybody between 18 and 29. And we're an aging population, and you know people are getting old. So even you are not old, you know your friends or your relatives getting old. It was a very scary time. It's this thing called infection fatality rates. 1.4% for COVID, I said. Very funny figure because people don't believe in it. The figure is too variable. So, and even if you think about it that way, 1.4% sounds very small. But my father used to say that when it's 1 in a million, it sounds great until you are that one. And all of a sudden, it's the worst thing on earth. Right? So in Jamaica, we had 156,869 cases of confirmed cases of COVID and 3,759 deaths. You see, the math doesn't work out to 1.4% because we don't test enough. But even if that's correct, 3,759 deaths, you would need 9 years of traffic fatalities to get that kind of figure. It was no joke. People are actually dying. And people are saying, oh, minuscule, and that was really horrible. So in your mind, you realize that it's a very serious thing. There was just too much. There was information coming from all sources. Then come to misinformation, a plethora of disinformation, and it was very confusing. I recall speaking to some churches at the time. I clearly remember telling them that you do not need masks. We're told by WHO, make sure you sanitize because droplets fall on the surface, so you wipe them off, and all these things were selling like crazy. And then not a week passed. I was so embarrassed. I had to tell the pastor to tell them, you need masks. And then what kind of masks? Oh, cloth masks. Then wait a minute, the pores are too big, and if you're supposed to wash them, and for every fourth wash, that's the end of that. And surgical masks. Then the Americans hugged the N95s, and then when you get them, did you fit it? And KN95. It was just these things add to confusion. It adds to stress. You became confused or traumatized. Too many opinions that people are supposed to be experts. Listen to this. I want you to know something carefully. When it comes to COVID, 1, there are no experts, and 2, it's very unpredictable. So to say they are expert on COVID, that's just ridiculous. So as you can see in the last sentence there, a lot of anxiety resulted that's carried over into this present time. The entire planet was sick. There's no way you could go to escape this blooming thing. There's nowhere you could go. Like you were, this is awful. In fact, as if our creator was not, he's called us, like, oh boy, we're bad off. So between the masking and the washing of hands and sanitization and the distancing, not natural for us. So the restrictions and so on called alteration, interactive society. I know we fight one another and kill one another, but we are still by nature gregarious. We still want people around us. this thing separated everybody. Hand washing, this protective gear, this thing up your nose. I have got a few tests done, remote learning, remote work, computer strain, phone, the phone was everything, virtual everything, sleep pattern change, eating habits, family routines. It were all stressors, and these things carried over because it was pushed us forward into stress. Exercise was disrupted. It couldn't go to anywhere, most places, at essential businesses. Supply of food was short, and you're forced to be family members all the time. Doesn't sound too bad until you're forced to do it for months. That's that things don't work out that kind of way. So again, more stress from COVID. Then at last, the COVID vaccine came, and everybody was saying, oh, good. But, well, some people are saying, well, it's here too fast, and then they're wondering, mRNA thing, it makes you make the thing, and then your body reacts to it, and it didn't sound good for some people, and it was a very stressful time for everybody because it was so stressful that people actually preferred to get this instead of that vaccine, the AstraZeneca. Instead, they would look for something else because even this, a beer, because the vaccine came with a lot of questions and doubts, and that again was very stress-producing for the entire society. Well, some folks did take the vaccine, poor uptake, but it was not well taken up at all by population, especially in Jamaica. It was very badly taken up. Some folks said it was as bad. It was basically it was going to kill you, worse than the virus itself. Some said, no, we don't want it. And because of that, there is joke about WHO was going to hire these people that were undecided to actually give it to them without their actually volunteering. It was very stressful, that vaccine thing. And it still goes on, as you know, to this very day. People who want the vaccine had valid reasons, you know. I mean, you have to respect their reasons. I mean, you might not agree with them, but low perceived benefit of getting the vaccine. They thought they mightn't get COVID, but anyway, what's the point? Adverse, as you know, right now, the long-term effect, people are worried about that. Some people had poor health literacy, they didn't know what was going on. They didn't trust big pharma, they're being planted by some tracer. And spiritual beliefs. I want to mention church again. I've been to a few churches to speak. And every time somebody gets up, like it's a representative, the person gets up, you know, people sort of look to them, you know, and they announce that if somebody takes the vaccine now, they don't trust God. In other words, they don't have faith. That's why they're taking this vaccine. Well, I know people who actually in church who didn't take it, and they died. They wondered, elderly people, these, what they call the church, the big people, elders, would they have lived? You know, I kind of wonder about that because the spiritual belief thing was very serious and very prevalent. More than people realized. Total lockdown. And we thought maybe the science would have, you know, the key to it all. It was a bad time. Broken heart, you know, this is what I like about this thing. 220 was as if, you know, holy crap, because it's funny. This was what 220 looked like, you know. Trash went out more than you, stuck inside the house. If you try to have a party, you'll be in problems. People were basically this way on the inside. I was saying broken hearts and of course broke pocket because some people couldn't earn a living, but some of our entertainers, which I came out and said, who for their dead because they didn't have enough, they weren't getting enough performances. One was Buja Banton, one was Beanie Man, and they would do things behind the back and get in problem, get arrested for it. I'm not going to go into details with this, but this is where the sort of thing really begins now. General stressors, family deaths. I had a death of, not family member, thank God, classmates, colleagues, many patients, a neighbor, friends, and I'm sure everybody can probably relate to that. Finance problems, time you couldn't go to your friends, learning problems, vacation, get messed up, travel, that's sports. I have a theater buff, I go to theater once every Friday with my wife. Restaurant, that was it, you know, concerts, but you can see it for yourself, horrible. And then somebody died for you. That's even worse because now you couldn't visit the person when they're sick. I had to be go-between for some people because they can't get to hospital, they can't hear from anybody. Lack of help, death was so random, fear of personal safety. The loved one died alone. That alone was a huge, I remember my neighbor who was dying, he called me from hospital. Oh, I don't like to remember it. The way he sounded, he was huffing and puffing, and you never heard people say these people run and they stop them to interview them afterwards. That's nothing compared to what he sounded like. And you could hear the high flow oxygen in the back. hissing away, and he does no accident was helping him. Anyway, and he was just at 40 years old. You know, so you feel helpless. No network. It was just a very bad time, which stressed out most, if not all of us. This is to do with us, healthcare workers. Quite a few of us died, and that is a collage actually, you know. And each thing you see, like there's somebody's face. You can see it really close up. Each thing you see in the green part and so on, that's somebody's face. A lot of health workers died. They were heroes, but they died. Very, very sad time. So this call went to people's head. I mean, this girl that went to her head literally. This is a picture of what the whole scene was like at the time. I want mother to go read little things, but it was darkness and gloom for most people. It was bad. It was bad. I mean, as time goes by, you know, but it was really, really bad. This guy, very interesting man. I don't think you recognize him. I think the psychiatrist might know his name. They call him Hans Selye. He was from Hungary, migrated to Canada. He was an endocrinologist, what they call the founder of the stress theory. And he used rats, I think it was rats, yeah, and he stressed them out. Not to hurt them, but he stressed them out. And some of them, their adrenals went wild and they died, literally died. Some people are saying, you know, stress, but the stress is not only supratentorial, it actually has somatic manifestations. So this is where he, you know, he said this, and he was right, and people realized, hey, this thing is serious, you know, don't take it lightly. So mental health, sensitive to traumatic events, and any sudden changes, our minds don't like sudden changes, our bodies either. If it happens suddenly, we don't really tolerate it very well. And two sides of the same coin. So if you were to, the last part says, if it's beneficial, if you were to, let's say, win a car and you get this much, reaction, and the car gets stolen, you get this much reaction, it's a magnitude, so much more than this, but it's part of our night. It's the same kind. And our bodies and our minds don't really like to be stressed out like that. It's considered stress. A marriage is stress, divorce is stress. These things are all stress. So WHO said that depression is a 3.8 of the world population. Actually, well, maybe I'll just stop at the for now. Noting that in our economy, we are called an upper middle class economy. Yes, upper middle class economy. It's worse. It's not very treated because people just don't treat it that well. I think in other more developed societies, they more accept the diagnosis of being stressed out or depressed, but we still kind of not there yet. So in the United States, depression symptoms in the US increased more than threefold during COVID-19 pandemic, from 8.5 to that. Anxiety and depression together were identified early in pandemic and it increased more than sixfold. So you see, the whole pandemic thing it wasn't pretty. So there's a study from NIH. They took out 1,470 participants, completed the COVID-19 and life stressors impact on mental health. Completion rate 64.3%. I hear it's pretty good. You know. And what happened is that because of COVID or during COVID, my depression increased by 24.6%, moderate increased by 14.8%, moderate severe 7.9%. You expect severe by 5.1%. And the stress experience was about 45.4% of people polled or rather investigated. People, those who didn't cope, had a higher level of suicidality, loneliness, lower self-efficacy, higher odds of having COVID stress probably. Those people didn't cope very well. That's a segment of people there. I'm not going to read this. This is DSM-5. I hear 6 coming out in 2026. But we can just look at it at a glance. I mean, our psychiatrists know this back to front, inside out. I'm not going to put it here to explain that this is what these things, you know, look like. But anxiety, it has more somatic problems, as they can see. I don't know, people talk about churning in the stomach, lightheadedness, nausea, need to go to the bathroom often, having panic attacks, feeling restless, pins and needles, all anxiety symptoms. And then there's this thing now with a rather unfortunate acronym. It's supposed to be a fairly new diagnostic category, defining patients who suffer from both anxiety and depression. Not one and that, it's like a combination of them. They don't meet the criteria for the specific thing, but it's like a combination. And they call it mixed anxiety and depressive disorder. I won't say that word because it's not a good word to say. Anxiety and depression are common mental health conditions. Anxiety causes a feeling of excessive worry and fear, depression causes feeling of hopelessness and despair. People can experience both of them. And during the pandemic, this actually happened. Enduring concerns, future with the pandemic, children with future harm, vaccine back again. As you know, AstraZeneca pulled the vaccine. They said because they had excess stocks, they weren't selling much anymore because other companies were making more appropriate vaccines. But a few months ago, you know, they admitted to this TTS thing. The thing is that, well, where I was thinking that if you could get a vaccine reaction about up to 3 weeks, but I mean up to 3 months, that's a long time ago. No matter what you know, up to 3 months, we heard last night. No, night before last night. But it is gone now, people are still fretting about it. With a better vaccine they found, still don't know as yet. This is sort of important because you talk about post-COVID, even the title, post-COVID, I'm coming to say it again, post-COVID. So if you look for COVID in a timeline, a specific timeline, you're not going to find it. It's here to stay, it's here, right? There's no real post-COVID. It's things like the emergency phase is over, and I put in for now, an ebb, and there's a lull. People talk about a retreat, which we'll see very shortly. It's not really gone. And in fact, to think of it, I had a patient come to me, it's probably a month, probably about 2 months now. Yeah, it was in heart failure. University Hospital, this man had COVID. No, there was no symptoms, no obvious symptoms. He overcame the heart failure, and then cytokine storm hit him, and he died. It's a few, and then I had 2 patients that day working from England. He was on a course, and he came, no smell, no taste, his wife, same thing. So it's around. What about our Jamaican situation? So Jamaican males, the study was done by NCU, November 2022, margin of error plus or minus 3%. And they said, let me move something in my way here. A little over half of the men experienced levels of depression in the retreat. There's the word of COVID-19. Depression levels recorded were 41% mild, 8% moderate, 4% severe. Nearly a tenth of them, of the study of 1,066 adult males surveyed, attempted suicide, a tenth, or had suicide thoughts, or wished that they were dead. And now 25% felt that life wasn't worse. It's very common, this depression thing. They said that they need to do more research into it, not as yet finished. I should mention that, well, obviously, the COVID pandemic precipitated the issue of depression among women more than men, which I'll come to shortly. What I found anecdotally is that if a gentleman or a man gets his job back, he tends to rebound better. But I have also found that several employers were use the opportunity, use COVID as an excuse to cut staff and impact the work on other people. And it's going on to this very day. So people are coming to me now stressed out because they're basically overworked. It's not COVID that did it, but people who use COVID excuse that did it to them. You understand? So what about the women? Given that women are concentrated in the sectors and industry that hardest hit by isolation measures, there are more problems than men in both waves. So women, 22.8% of Jamaican women are classified as having severe depression, 0.4% suffered very severe depression, majority 68.9%, abnormally high prevalence of depression in Jamaican women, right? But all through the whole gamut of it. Some people and I were talking about this, and they pointed out that although we don't realize it upfront, our society is matriarchal. Women, they have to work like men, by the way, most of them, and they have to take care of the children, either the mother or the grandmother or the aunt. If you think about it, if you're an observant person, you drive on the streets, you don't see a man carrying, what they call it now, groceries. You don't see a man, I don't see a man carry groceries. Women work very hard. They're the ones carrying the groceries, buying the groceries in the supermarket. When I go and shop, they look at me funny, when they come here and smile, as if he must be a nice guy, because the guys just don't do that, right? So women, naturally, they go through more stresses of life, and through COVID, just became worse, basically. Women are more affected profoundly. This is something that we can read through it. They said severe depression is more impacting women over 40 years old. The working class experience the highest amount of depression and hopelessness because they saw no way out of their sorrows. If they had a loss, like somebody died for them, it was worse. It can't come back from PTSD, very rough. Again, people who can't cope, people who have lowest level of exposure to formal education, they couldn't cope very well. Women dwelling in urban areas didn't cope very well either. Of a sample Jamaican women is something I found very interesting. Of the sample Jamaican women with 1186, none of those samples fell into the no depression classification. It's kind of sound away, but if you, in that particular study, they said that the 18 years and over, all of them were actually experiencing depression. Well, you know, they should extrapolate to the whole population, but in that study, of course, my reaction to it was like, what? To be more precise, my reaction was this, because, you know, it kind of looks too much to me, to you know, everybody. Anyway, so maybe again, I was the way. So this is an important part because in the pre-test, women 6.4 times higher depression rate than men. So it's a gendered phenomenon. And now it's an epidemic, which I'll speak to shortly. In addition to finding from the current study that 90% of Jamaican women indicated that they probably would have been better off dead. On the other hand, I found only 5% of men thought the same. Now, if you think that you're probably better off dead, obviously you're depressed and you're possibly suicidal. Our own Professor Abel noted that this whole thing should be a public health concern in Jamaica. And you know that women might think about it more, but men will actually kill themselves because they're more determined to do it. So because of COVID, you got this whole depression and anxiety. Signs of depression in Jamaican women are clearly at an epidemic stage. And clearly COVID-19 has created national public health challenge that requires immediate resolution. I don't see it happening, but that's what they said. Now, what about the kids? It's a top-of-narrative statement. Letter of the day talking about the crippling effect of COVID-19 on nation's children, published last year. The COVID-19 pandemic has disrupted every aspect of our lives, but perhaps none more than that in our children. From disrupted education to increased social isolation, the pandemic has a profound effect on their well-being. You know, this whole homeschooling thing, the school comes into your home and some people might forget. So it's like it's very invasive. So if you're not careful, this camera is on and things happen that is to people. And some children couldn't have access to it. People had to be buying, they call it prepaid on the phone and trying to buy data. And those lost out very badly because obviously they were losing out on the classes. And not an inconvenience only, it's for the future academic career. And it's taken a different toll on their mental health because the social isolation, anxiety about the virus, and the disruption of daily routines have all contributed to increased rates of depression and anxiety among children. Many children don't have access to resources to actually deal with it. The resumption of classes had problems because some children just couldn't cope. They were sleeping in class, they missed class for 2 years, they couldn't catch up with their schoolwork, they had headaches, they couldn't think again because they're in a different mode, the home mode. The factors were serious. Social media, another thing we heard about a while ago, they're addicted to it, they're into substance abuse. It was just horrible. Academics got a big lick from the fact that children were home for about 2 years, but they had to do it, it is thought. Now they're reviewing that, but the fact of the matter is that it had a bad effect. Just a splash of things, but I want to look at the violence part of it. What I find is that if somebody has emotional stress and they're in emotional pain, which is very, very painful, some say if you can't get rid of your pain, you act it out in violence. And they had violence in the schools and still have it up to this day. They're fighting one another. They're fighting the teachers. Even the good schools. I mean, it's supposed to be quote unquote a good school, Meadowbrook High. Fight broke out. Unfortunately, some ended in death. That killing last Monday, I think. Stabbing. The children are really acting out badly. And of course, eventually they're going to end up with some of them. Unfortunately, they never get over it and they can't catch up ever. And you get this this is the future of our nation, and some of them end up just like this. And Carter High School did something good because they were fighting every day, basically, since face-to-face came back. The admin realized this, and they said, boy, this is not going to work. And the children not coping, and so they had council departments redouble their efforts, and they had counseling for the children, which is what you need in those schools anyway. It should be done prophylactically, it wasn't. But anyway, they did it, and in that school, they got a complete turnaround. And the elderly, the aging population. This is a gentleman I want to talk about. A patient of many, many years. He was a loner because his wife forged a signature to import something, and he found out and she get vexed to the children that went abroad. He lived alone for years, but he had his church. I have a church where the walk is a walk a lot. So I drew this picture, is a walk a lot. And then came COVID. Church ended. He wasn't good at this online thing. In fact, I just mentioned my mother, she lives abroad and they moved from New York to here to Atlanta. And she had an online thing, right? And my sister warned her that, the mic, careful, the mic is open. And this guy is away in New York and she didn't like the way he preached. And he came on. My mother shouted out, "I can't stand that man," of course. The entire church heard. But funny, he actually put up his socks, But this gentleman couldn't be with the online thing. He had a hard time with no more walking partners. He couldn't go out and walk anyway. And then this happened. Now, but he said telebanking, he came here and basically, he just couldn't deal with telebanking. It was crazy for him. So he went to the bank and then I watched this man disintegrate little by little. Piece of it just flew away, like he was just falling apart. When he went to the bank and tried to get help, they pointed him to the ATM. And he came and complained and the bank wouldn't listen. Just the last little interaction left for his life. Anyway, he became terribly sick and had to go on medication. And despite medication, Mr. H died a lonely, broken man. He did not die from COVID, but he died because of COVID. And these things happen and people don't seem to realize it. So this lady now, this is kind of interesting. No, wait, I'm going to answer a question. This was just before COVID, 2020, just before COVID. How old do you think she is? Or was at the time? She's still alive, by the way. She's still alive. How old? Anybody want to hazard a guess? I'm curious what people think. This lady, at the time, very ebullient. She went out on basically by herself, just want to watch her. Coronation market, which I wouldn't want to go. Regular supermarket, she went shopping for other things. She went to the bank herself. She went post office for herself. She went to pharmacy for herself. She came here. How old do you think that lady is? What do you want
We're
to get?
seeing some ranges here, Garth, between 75 and 90. That's what the range I'm seeing here on the chat.
103 years old. And she's still alive today. Not the same person because COVID shut her down. She couldn't get to go out anymore. And you could see her kind of involute. In fact, she used to bring her nephew, a 95-year-old man here. And just like her son, because she had no kids, right? And she would bring him and say, "Tell the doctor, they sit in the corner." Anyway, bad luck, stove problems, and the nephew went to help her and so blew up on him. He was in front of her. Went to hospital to get dressing. He wasn't admitted, but back and forth, he picked up COVID in hospital, brought it home, and they both got COVID. They were not vaccinated. And he died. Strong 95, well, 95. And she survived. Not the same person anymore. You don't see that smiley face anymore. She will try, but this COVID thing, let me tell you the truth. It is horrible. And you see these things, that's very, very painful. Anyway, she's still alive. In fact, the other day I was signing her life certificate on a page. As a patient, this lady is 107 years old. I'm signing it. The lady says to me across the desk, she's still alive. I was like, oh, I'm signing the thing for heaven's sake. So they found that people who got diagnosed with COVID, a fifth of them had psychiatric problems, anxiety, depression. And 1 in 4 of people never had a problem before. Never before, they were fine before. But since COVID, they got diagnosed with it. And of course, if you have long COVID, tell me about it. You experience mental health issues, PTSD, lethargic fatigue. Even those who are not tested positive, but just the trauma of being in a place that had this COVID thing going on. And concern about mental health and substance abuse remain elevated 3 years after. I went back again because I wanted to look. We'll go slowly. Concerns about mental health and substance abuse remain elevated 3 years after the COVID pandemic. So it's still going on today. So KFF is an independent source for health policy research, polling, and journalism. They had a survey with CNN. They found that the pandemic has affected the public's mental health and well-being in a variety of ways, including through isolation and loneliness, job loss, financial problems, illness, and grief. I have quite a few patients who are still grieving over the loss, quite a few. people who died for them. You know, even the pandemic, link between it and mental illness, mental problems, there is still more research needed to be done because it's really quite impactful. What about us? What about doctors? So where we are here, and we have the doctors around the place. And I want to put this up because it comes down to this really. People don't look, when patients come in, you know, you might be doing something, you don't look. I remember a neurologist said to me, when a patient comes to the office, look, observe. You can tell a lot from somebody who walks in the office. It's not to do with this, but one day a gentleman came in the office and I watched him, he sat in the chair, said to him, hemorrhoid problems. I didn't know the guy. How you know? Because he sat there, you got a catch, right? You have to watch, look at people, look at them properly. You can tell about the demeanor, how they're feeling and all of the things. Listen, and I want to mention this to you. Dr. Owen James told us some years ago that we don't listen for very long. About 18 seconds, they will interrupt. And guess what happened? Of course, Dr. James, he was right. They said that within little below 18 seconds, we interrupt patients. And if left alone, most people will tell you what they want about just a rough thing, about 47 or 47.8 seconds. But no, we interrupt and we lose out. We lose out because we don't get to hear real depth of what's going on, right? To listen. With this thing with being anxious and depressed, the man come to you for that. But the way they talk and what they say, you can say, wait a minute. And we should talk last, right? We should talk last. But we tend to talk without looking and without listening for long enough to put them up. Talk too fast. The second question I put in there for the pre-test, just a rough thing about the overlap between depression and anxiety, agitation, no concentration, irritability, irregular sleep. It's a brief list of what the overlap is, because they tend to look very much alike in those cases and differentials. This is very important, very important. I remember I saw a gentleman who was a family friend too, worked on a ship, and he was not feeling well, went to the ship's doctor for a checkup. This is years ago. Doctor said to him, Mr. So-and-so, you have an anxiety symptoms, right? And he was like, okay, tachycardic a little bit, but usually a fit guy. Came to Jamaica, he just called me and said something wrong, man. So he came to the office. Long story short, he was anemic. Long story short, blood loss due to colon cancer, which killed him. He died. And he wanted to himself, what if the doctor didn't just assume anxiety? You know, tell the man, check him. So we have to be careful. We don't assume these things, although, be careful. Next thing, I saw a lady who, she brought it to me. She was on her way home from a hospital, a major public in Jamaica, Kingston, public hospital, in a wheelchair. I said, what's going on? She's straight. She basically stopped walking and looked very sullen and melancholy, quote unquote, and stopped talking. So they took her and they thought she was psychiatric. They couldn't find anything, wouldn't talk to anybody. Long story short, she came and I said, why check her vitamin B12? And would you believe they didn't? Got her the shots and her mind came back, but her leg never came back. I could go on, with on and on and on. So differential is very, very important. Don't assume, although the person might seem anxious. In fact, well, don't assume, right? Because, it's a differential, it's a diagnosis you make by exclusion. Check other things if you see something up front. Yes, person might say, I'm depressed, I'm feeling this, I'm feeling down. And so run some blood tests, check on things. If you have memory problems, do a scan, do something. Don't assume anything. Because electrolyte imbalance, people get old, the sodium go off, whack, drop. I've seen it. It's a long story, but you guys know all of this already. So I'm just saying to remind you, don't assume. So if you think it's anxiety, you want to spend time speaking with the patient, If you really think it's that, prescribe something, and they will take it. If it's something stronger, if not, refer to a psychiatrist or a psychologist. I want to mention one of our top psychiatrists who is still working today. He had a patient seen at my patient. He said the worst case of anxiety he's ever seen. As refer, that's it from early, because he wasn't really responding to the medication. If you think the depression, speak with them, prescribe it. But I stopped there, because if they don't improve within 2 to 3 weeks, usually 2. But, still cannot say, that's it, I refer. Until they hanging on to business, right? Because they are the ones who are important, not us. We are there for them, not the other way around. This is just a brief thing about the 3 C's. It went to end up being this, basically, but go back to that. Calming yourself, prayer, I suppose. Prayer, well, it can calm you, and people say it has other effects. I'm not a person where it's a scientific session. I believe it works. I could tell stories, but like I just say, meditate, pray. Cognitive restructuring, which is something that I don't know much about. I think to do somebody who can do it for them, challenge negative thoughts, positive visualization. Communication is very important. People keep their words to themselves, not will express emotions, find somebody we can speak with to get and this is what it looks like. Okay, meditation, restructuring, reconstruction, and speaking to people. And this is it. WHO aptly summarized the mental health epidemic following COVID-19 this way. Plenty of us became more anxious, but for some, COVID-19 has sparked or amplified much worse, much more serious mental health problems. And family doctors, as you heard before, we are on the front line. We must endeavor not to drop the ball. Look, listen before we speak, expect it. You know, it's out there, check it out. We must know what to do, and we must know when to refer. Don't hold on to people. Yes, I look through all these things to do this. Thank you very much.
Thank you, Dr. Rattray. A rather interesting presentation, looking at the whole, primarily focusing on anxiety and depression, but looking to the mental health consequences of the COVID occasion, I would like to put it. So not so much those who have just been infected, but the experiences of all of us during that period in our lives. All right, colleagues, it's now coming on to that point in time. We would have a sponsor's presentation based on my notes here related to the medical protection service. That's a sponsored presentation. Does Mr. Russell on? Is it Paul? Is it your time or is it the MPS people?
It's MPS.
Okay, great. All right. Lead us through this one, Sam.
So good.
All right.
Good day, ladies and gentlemen. Dr. Reed, it's
Yes.
Medical Protection Society, not
Right.
services, a slight typo there.
Okay.
I have been enjoying the sessions and I'm learning quite a bit. And yeah, it's been a wonderful opportunity to share here with you. I have a short presentation to put up, short, sweet, and spicy, because I know your time, your bandwidth for presentations can be limited. And it is good to see some old familiar faces. Right, Dr. Rattray?
I know you said that. I knew you said that, you know.
Of course, I had to slip it in. I absolutely had to slip it in. So my name is Ruth Ross Hutton. I'm the development manager for the Medical Protection Society for the Caribbean and Bermuda. And I just want to give you a brief overview, reminder for some and update for others. I'd like to put in a disclaimer. If you do see or hear anything untoward, I am at another function, I'm multitasking, but I absolutely had to be here today to speak with the attendees for the Caribbean College of Family Physicians. So MPS, Protection Society, is not an insurance company. We are a non-for-profit, mutual, member-owned, and we've been around for quite a while. When I joined MPS, it was interesting to note their ethos, that they support safe practice in medicine by helping to avert problems in the first place. And it always brings me back to my grandmother's saying, you know, an ounce of prevention is far better than a pound of cure. So we exist to do one thing. It's to support our members in times of need. MPS has a global footprint across the Commonwealth, and we've been in existence for over 130 years. And throughout that time, the business has been growing. In 2019, we made the decision to invest in a local team within the Caribbean. And so I want to introduce to you very quickly the team. There's a business development exec, Stephen. He's based in Trinidad. We have Dr. Brian Charles, our consultant. He's based in Barbados. And Andrew Bromfield, our local consultant here in Jamaica. Well, how do we support members? Many ways. Starting off with dealing with challenges and issues that arise from the workplace, disciplinary matters, complaints, medical counsel investigations, help with unwanted media attention, regulatory proceedings. All of these are examples where we do provide for our members legal services. And when I say legal services, and it means an attorney is assigned to you, an attorney based in Jamaica. Yes, they prepare you, they guide you, and they represent and speak for you at all of these hearings, and they guide you accordingly. We have a 24/7, 365 medical legal help desk, and we do encourage members to use this. Call. It's better to call and ask. It doesn't affect your annual subscription. You're not asked to pay more. Just call because it benefits you at the end of the day. Listening to Dr. Rattray's presentation about the effect of COVID, I have to interject and state here also that we provide confidential counseling service to our members. Each member can have up to 6 sessions with this counseling session, and third-party counseling organization. And it's part and parcel, whether it's a lawsuit, whether it's stressor, whatever the situation, if the need is there, the service is there. And you can access this by going onto our website, looking under the well-being area and setting up an appointment. Now, the biggie is the clinical negligence and claim support. And this is where if you're sued for clinical negligence, you have the right to seek legal representation and advice. And again, it's the same thing. The same benefits are afforded where an attorney is assigned to you from Jamaica, or a panel firm in Jamaica is Livingston, Alexander and Levy, and they will be getting their instructions from our legal team in England, and they work together to either defend or to settle out of court. Whatever the situation may be, you will have that full support. And the good thing about MPS as it relates to doctors and members here in Jamaica, you are indemnified for up to a max of 270 million Jamaican dollars per claim per year. Yes, you can be sued more than once in a calendar year. No matter how you may think it can never happen, the possibility definitely exists. So you are getting an extensive set of experts, local, regional, and international, there to support you and to provide the best end result for you. When we talk about expert legal teams, as I said, MPS being in our existence for over 130 years, we have all of that data, all of that expertise at our fingertips, ready to guide, ready to provide the support that is required. So one other quick thing to share with you, for our physicians who work either full-time private or, full-time private, they work full-time in the hospital or in a government setting, and they do part-time private work. We have what we call limited part-time practicing grades. This came with COVID. Initially just started because a lot of members opted to close their offices and working significantly less time for the day, for the week. Some just decided the risk was too much and stopped working altogether. So we did a survey, and from that we crafted limited part-time grades, where these grades are based on the average hour of work each week over a 3-month period in your private setting. Yes, and as you can imagine, the less hours you work, the lower your subscriptions would be, vis-a-vis somebody working 40 hours full-time. Of course, you're at the top tier. But this is a great opportunity for doctors who are working on either scale, that you have this as an option to note. Now, one critical component, just like with most other organizations, if our primary way of communicating with members is electronically, but if you change your email address, you change your telephone number, you change your place of work, you change your type of work, if you don't inform us, you will never know. So the onus is always upon you to update us on any changes that may occur within your professional space, so that you can be covered and indemnified accurately. With that, I say, if you have any questions, any queries, if you're gonna grab a screenshot of anything, make it be this one. My email address, telephone number is there, and our website, www.medicalprotection.com/Carbon and Bermuda, and you can get all the information that you want there. One of our biggest beliefs with MPS is risk prevention, and we're big on sharing meaningful, practical, applicable really information that will help providers to avert the risk in the first place. If we are able to do that, then our job is done. It doesn't matter about providing indemnity. It doesn't matter any of all. I mean, all of that is gravy, but we really want to create the awareness to guide and to assist to avert risks in the first place. But should they occur, we are here. We're just a phone call, an email, a click, a text message away. And with that, I say, if you have any questions, please feel free to utilize the Q&A function in the webinar, and I'll do my best to respond to them because I am cognizant of the timing issues with the webinar. And with that, I hand back over into the capable hands of the illustrious, eloquent Dr. Marvin Reed.
Thank you so much, Mrs. Russell-Hutton. So colleagues, you have been advised. So please use the Q&A function to get further information from Mrs. Russell-Hutton about the offerings of the MPS Society in terms of what they have to offer for indemnity, in terms of counseling, or what other services that you think may be beneficial to you. Colleagues, we're coming to the end of session 1, and we really had a very diverse and interesting session. We started off with Dr. Paula Henry just alerting us to the fact that we're all at risk from climate change and the effects of severe hurricanes and other planetary effects on our environment and the consequence that has on our health. We're taking on a journey of artificial intelligence, just defining what it is and how artificial intelligence can help us in diagnosing and in personalizing our therapeutic interventions for individuals with chronic diseases and in particular asthma. The caveat was placed though on the table that as we develop these artificial intelligence systems, it's important that as a Caribbean society, we also get involved in that ecosystem so that our data is included, so that the outcome of these precision or these artificial intelligence algorithms are adjusted for our unique scenarios. We were then entreated to a description of the different projects that the Ministry of Health and Wellness is embarking on to improve mental health wellness within the community and the workplace. So we started looking at Employee Assistance Program. This is a workplace initiative. We look at PM Plus, which is Problem Management Plus, which is something that we can do in the community, and Mental Health Literacy Program, which is a program involved in the school. And Dr. Goulbourne told us about the plans to integrate mental health services within primary care setting. We were then shared by Dr. Ganesh Shetty, who spoke to us about the impact of the different technological platform and how that was affecting in particular our adolescent mental health. And he invited us to try and identify and have open conversations with our patients to promulgate and promote screen time guidance, as well as to educate our patients and clients about the benefits and harm of technology. And we concluded this section with a presentation from Dr. Garth Rattray, who outlined the potential tsunami of mental health problems that are likely to arise from the COVID pandemic, with an emphasis on depression and how it was differentially affecting males and females within the Jamaican society. And he did put forward his solutions or some interventions that we could consider to address the rise in the mental health disorders, in particular depression amongst our patients. So colleagues, we had a very rich and informative session. I will not prolong you any longer. The formal thank you will come at the end. Just to say that I'm Marvin Reed. I'm the president of the Caribbean College of Family Physicians Regional, and it was indeed my pleasure to act as your moderator and host for this session. I will now hand over to the moderator, Dr. Pauline Williams-Green, who will then guide you through the second session. Dr. Pauline Williams-Green.
Thank you so much, Professor Reed, and for giving us that wonderful overview. Good afternoon. What an exciting, stimulating morning it has been. I'd like to just congratulate the World Family Doctor Day Committee. They have put together a really wonderful package of speakers and topics, which not only stimulate our minds, but have given us much food for thought. And of course, Professor Marvin Reed ably piloted you through that exciting ride this morning. Now I'm taking over and I'm asking you, please, to relax. First, we're going to have our sponsor, Paul Russell. Of course, I hope you've been walking around and stressing and stretching. Please do that, even as you listen to Paul Russell from Abbott. Please go ahead, Abbott.
Good afternoon. I'm hoping I'm unmuted. Am I unmuted?
Yes, you are. Go right
Okay.
ahead. We hear you well.
Yes, good afternoon. My name is Paul Russell from Abbott Nutrition, and I want to thank the World Family Doctor Day Jamaica Committee for the opportunity to present some of Abbott's products to you today. So Abbott Nutrition has been providing nutritional solutions for over a century, and their products cover several stages of life, from infants to young adults, families, and aging, and for persons with special health needs. So we're going to take a look at a few of them. First one we're looking at is Ensure Plus, which provides concentrated calories and protein to help patients gain or maintain healthy weight. It can benefit patients who have malnutrition or are at nutritional risk or are experiencing involuntary weight loss. Ensure Plus has 350 calories, it's calorically dense per bottle. It's 16 grams of protein and has an excellent source of vitamin D and calcium to support bone health. And also has plant-based omega-3 fatty acid, ALA, to support heart health. For persons living with diabetes, there is Glucerna Hunger Smart Shake, which is a delicious meal or snack replacement to help manage blood sugar and hunger. Glucerna Hunger Smart has a unique blend of slow-release carbohydrates designed to help minimize blood sugar spikes, and it contains 15 grams of protein to help manage hunger. It also has 4 to 6 grams of fiber. There are antioxidants, vitamin C, vitamin E, and selenium to support the immune system. For our toddlers, there are 3 pediatric products that we have in our market available through the retail outlets, and that's Pediasure. Did I say Pedialyte? Sorry, Pediasure Grow and Gain, Pediasure Grow and Gain with fiber, and Pediasure Sidekicks. And this one in particular has a higher protein content than the others. It's lower in fat and lower in calories. So Pediasure has been helping kids grow for more than 30 years, and it can be used as a snack, can be used in recipes, or it can be given with meals. Now, all of the presentations I've put forward this afternoon, Ensure, the Glucerna, the Pediasure, they're all gluten-free, and they're suitable for lactose intolerance, and they come in a variety of flavors. And the final product I'd like to highlight today is Juven. For optimal wound healing, it's a therapeutic nutritional drink mix with a unique blend of key ingredients to support wound healing by enhancing collagen formation in as little as 2 weeks. So when a patient needs more than just protein, Juven can help. Dosing for Juven is 2 sachets per day, and it can be added to water or juice, not hot water. And it provides amino acids, arginine and glutamine. It has HMB and hydrolyzed collagen, along with micronutrients, vitamin C, vitamin E, B12, and zinc. Now, all these components are important to the wound healing process, and the results can be seen in as little as 2 weeks. I've included my business card with said number 876-489-6093 and my email address paul.russell@abbott.com. Should you have any questions, queries, or concerns regarding any of Abbott's nutritional products, please feel free to make contact with me. Thank you and enjoy the rest of the conference, and I appreciate the opportunity to present to you.
Good day, this is Health 2000 Canada, or H2K, a generic pharmaceutical company proudly serving Jamaica and the Caribbean since 1999, bringing you products made with the best ingredients, delivering efficacy, safety at affordable prices.
H2K Metformin XR for type 2 diabetes treatment. H2K Metformin XR is the extended release formulation of metformin. It is designed for once daily oral administration to help manage blood glucose levels. It decreases hepatic glucose production, increases insulin sensitivity, and enhances glucose uptake by muscles. H2K Metformin XR has 3 main benefits. 1. A steady release of the drug, reducing the risk of gastrointestinal side effects. 2. Improved adherence due to once daily dosing compared to 2 or 3 times daily for regular metformin. 3. Better for patients who experience side effects from the immediate release form.
Did you know that H2K was the first generic company to bring metformin extended release to Jamaica, even before the brand company did? Yes, we did, giving many diabetics the option to reduce pill burden, reduce GI issues, and helping with compliance. Yes, that's us, a company that cares. Here are a few more product reminders. H2K Tamsulosin hydrochloride modified release 400 microgram, the prostate selective alpha blocker to relieve BPH quickly, safely, and with exceptional tolerability in long-term therapy.
SCAZI, azithromycin suspension. Azithromycin is an antibiotic used to treat a wide range of bacterial infections. It works by stopping the growth of bacteria, which helps the body fight off the infection. Commonly used to treat respiratory infections such as pneumonia and bronchitis, as well as skin infections and ear infections. A 3-day regimen of SCAZI is as effective as a 10-day regimen of co-amoxiclav in the treatment of lower respiratory tract infections. One of the benefits of SCAZI is that it's available in a convenient once-a-day dose with fresh mint flavor. SCAZI. Dawacoff, an expectorant and bronchodilator. Dawacoff contains bromhexine, menthol, salbutamol, and guaifenesin as active ingredients. Dawacoff is used for the treatment of asthma, bronchitis, coughing, colds, chest congestion, breathing problems, and similar conditions. Dawacoff works by decreasing excessive mucus in the respiratory tract, making phlegm thinner, temporarily relieving minor chest pain, relaxing and opening the airways, making it easier to breathe. Dawacoff.
H2K Loratadine 5 mg per 5 ml delivers fast, non-drowsy, indoor-outdoor allergy relief in as fast as 1 hour from symptoms of runny nose, sneezing, itchy watery eyes, itchy throat or nose within 24 hours. Also available in tablets.
Feeling thirsty? Dehydrated? Hydrate with glucolite rehydration salts, a great way to replenish electrolyte loss from vomiting and diarrhea, exercise, fever, traveling, and hot weather. Rehydrate with glucolite. Just mix 1 sachet to 1 liter of water and consume within 24 hours. Enjoy. Glucolite. Stay hydrated.
Are you feeling tired and weak? Not eating properly?
Recovering from an illness? Take Vitamax, the complete sugar-free multivitamin mineral syrup with over 15 essential vitamins and minerals the body requires daily. Take Vitamax to boost your immune system, enhance your appetite, and boost performance with added antioxidant support. Kids love the taste, adults love the benefits. Vitamax, for overall good health in one spoonful. Vitamax, the complete supplement for the whole family.
Please follow us on Facebook and Instagram. Thank you for listening. All our products are available in pharmacies island-wide. Please ask for it. Doctors, please write H2K before the drug name on your prescription. Have a wonderful day and be safe.
At this time, we will welcome, well, we're fully into our second session, and we would welcome family medicine resident, Dr. Martina Williams. She will be presenting her work titled Social and Neighborhood Factors Associated with the Presence of Depressive Symptoms in Adults Living in St. Catherine. And I'm happy to hear this. We're looking forward to your presentation. Dr. Martina Williams, please go ahead. Remember, you have 20 minutes only.
Good afternoon. I am Dr. Martina Williams. I'm a recent graduate of the Family Medicine program. And today I will be presenting my research project that was entitled The Social and Neighborhood Characteristics Associated with the Development of Depressive Symptoms in Adults Living in St. Catherine. So this project was done in partial fulfillment of the degree of Doctor of Medicine in Family Medicine, and it was done with my supervisor, Dr. Standard Wilson. So today I will be presenting according to this outline, and some slides may be summarized in the interest of time, and it can be revisited at the end of the presentation. So I'll start by introducing some statistics related to depression. So worldwide, depression affects 280 million persons. And according to the Global Burden of Disease 2019 study, it was one of the top 10 contributors to disability-adjusted life years. It's also one of the leading causes of increasing global disease burden. So in the Latin America and Caribbean region, the prevalence of depression is known to be 9.8%, and it is also the largest contributor to years lived with disability in the Caribbean. These are some statistics from other Caribbean countries. So according to the Jamaica Health and Lifestyle Survey, the national estimate of depression was 14.3%. And it was also noted that the prevalence of depression in urban men and women was higher than the overall figures noted for each genders. So in my literature review, factors that were associated with depression include age. So it is noted that depression is more prevalent in the young to middle age groups. And also for gender, it was noted that there are more females diagnosed with depression than males. The factor of marital status showed some conflicting results in the Caribbean as to whether it was protective or it increased the risk of depression. So a study done by Brown et al., which was a systematic review done within the region, showed that Jamaica had a higher prevalence of depression amongst married persons as compared to other Caribbean countries. Residence and education was also seen as factors that were associated with depression. So my focus is more on the neighborhood characteristics. These include, well, the neighborhood characteristics that have an association with depression include the physical characteristics as well as social or functional characteristics. And for social, this includes social cohesion and social disorder. In our population survey, which was done in the Netherlands, it suggested that the social characteristics, such as social cohesion and social disorder, had a greater influence on depressive symptoms than the physical characteristics of the neighborhood. it was seen that social cohesion and safety were associated with decreased levels of depression, while social disorder had been associated with increased severity of depression. Stress was noted to be a key mediator. In Jamaica, Mullings et al. Had studied the influences of urban neighborhood characteristics and gender differences on depression in Jamaica. And in this study, it was concluded that the physical neighborhood characteristics had an increased association with depression in men, while the urban woman faced increased stressors due to environmental and social hazards. There were no associations made for rural communities. The 2018 preliminary Jamaica Health and Lifestyle Survey was done on adults in Jamaica, and it noted that depression was more common in participants that perceived higher levels of crime and lower levels of safety. There were no differences noted between the urban and rural neighborhoods in this study. So the reasons for doing this study include that previous studies had noted a small difference in the prevalence of depressive symptoms in urban areas as compared to overall estimates. And I had like to explore the other experiences that could influence depressive symptoms and compare these factors in the different neighborhoods, so urban versus rural. These other experiences include social cohesion and social support. One might ask, why St. Catherine? So I believe that St. Catherine is deserving of community-centered research because it offers a large population which had similar urban-rural distribution as the general population. And also it has a high incidence of crime which is affecting the residents of the parish. The aim of this study was to identify factors which influence the development of depressive symptoms in adults living in urban as compared to rural communities in St. Catherine. The hypothesis is that exposure to poor neighborhood social characteristics and poor perceived social support is associated with the presence of depressive symptoms in adults living in St. Catherine. So there are 7 objectives, and these include to determine if there's an urban-rural difference in depressive symptoms, social dysfunction, and social cohesion. Also, to determine if there's an association between the experience of interpersonal violence and depressive symptoms, the presence of depressive symptoms and the level of social dysfunction and social cohesion in the neighborhood, perceived social support and depressive symptoms, as well as neighborhood social characteristics and perceived social support. So this study was a cross-sectional study, and it included, in the study population, it was persons 18 years and older who lived in St. Catherine. The inclusion criteria was any person who was 18 years and older who attended one of the chosen health centers in St. Catherine who also live in St. Catherine. Exclusion criteria. So persons who were excluded from this study were any person who was visiting or living in St. Catherine for less than 3 months, or adults who were unable to give informed consent or who were suffering from acute severe illnesses at the time. Sampling was multi-staged. In stage 1, this included dividing a cluster of health centers in St. Catherine into 2 groups, urban versus rural. And stage 2, St. Jago Park Health Center was chosen as an urban site. Kitson Town Health Center was chosen as a rural site. And then for stage 3, every second person registered for the day was selected. The sample size was calculated using the Rarasoft software, assuming the prevalence of depression to be 20% as per previous study, Mullings et al., at a confidence interval of, or a confidence level of 95%. This produced a minimum required sample to be 246 persons. The necessary ethical approvals were given. So data collection was done using interview-assisted questionnaires, and the questionnaire consisted of 44 questions, which took approximately 20 minutes to complete. I will now discuss the measures and operational definitions of the variables of interest. So first is the depressive symptoms, which was measured using the Patient Health Questionnaire 9, which is a widely used tool within the primary care setting. Now for the independent variables. So social cohesion, which is the term that is used to describe how people in the neighborhood assist, socialize, and trust each other. This was measured using responses to 5 questions, and these questions were assessed on a 5-point Likert scale. These are the questions. For social dysfunction, this is defined as the negative ways in which persons behave in the community. And it was measured by recording the frequency of occurrence of 5 violent acts within the neighborhood. And this was assessed on a 5-point Likert scale. Also, there was one question based on the personal experience of violence. These are the 5 questions, and this is a question for personal experience of violence. Perceived social support was defined as a subjective assessment of the adequacy of support given. So it was measured using the multidimensional scale of perceived social support, which was a 12-item questionnaire which gauged support in 3 different domains, this being family, friends, and significant others. The universal variables that were include these demographic variables listed on the slide. Also, possible confounding variables were included. So data analysis was done using the Statistical Package of Social Sciences, also known as SPSS, and the data was analyzed according to their descriptive characteristics. Weighted analysis was done using ratios, which were calculated from the population distribution in St. Catherine and the sample composition distribution. Weighting was then applied to the sample according to age group, urban and rural distribution, as well as sex distribution. Associations were analyzed using the appropriate non-parametric statistical tests, and the results of the analysis that were considered significant would have been those who had a p-value of less than 0.5%. The sample included 252 adults, and those persons were persons greater than 18 years old who attended the following health centers. So this table shows a description of demographic variables to which weighting was applied. So this includes the neighborhood, sex, and age. It also shows the distribution within the sample and the distribution after weighting was applied, so the weighted population and then the actual population. The urban-rural distribution in the sample was approximately split, while in the weighted population, it was closer to the distribution of the actual population of St. Catherine. In the sample, it was noted that there were more females than males. And in the sample, it was noted that the highest proportion in terms of age group was the 45 to 54-year-old age. However, after weighting, the weighted and actual population, the 25 to 34-year-old age group now had represented the highest proportion. So the prevalence of depressive symptoms in St. Catherine, as found in this study, was 25%, most having mild symptoms. So I'll now present the associations that were made in relation to my objectives. So age was noted to be significantly associated with depressive symptoms, and the age groups were recoded to conform to the rules of chi-squared, with the highest frequency of depressive symptoms being noted in the 18 to 34-year-old age group, and then after the 55 and older age group. Sex was noted to be associated with depressive symptoms, and it was noted to be higher in females than males. The Mann-Whitney U-test was used to perform to evaluate whether there was a difference between social cohesion or dysfunction in urban versus rural communities. So it was found that social dysfunction was higher in urban communities as compared to rural neighborhoods. For social cohesion, no difference was noted between urban and rural neighborhoods. Analysis of perceived support within the sample revealed that perceived support from a significant other achieved the highest score of all 3 domains, followed by support from family and then support from friends. The Mann-Whitney test was performed to compare the scores of social support noted by the neighborhood. The results showed that persons living in rural areas perceived more support in all domains compared to those living in urban areas. Simple linear regression was used to predict the social cohesion score based on perceived social support in each domain. It was found that perceived social support could explain 12.3% of variance in social cohesion. So with every increase of 1 unit in perceived support from family and friends, the social cohesion increased. However, for every 1 unit increase in perceived support from a significant other, social cohesion was noted to decrease. So the results of the Mann-Whitney test showed no difference in depressive symptoms between urban and rural neighborhoods. Simple linear regression was used to predict PHQ-9 scores based on the social cohesion scores, and social cohesion explained 10.5% of the variation in depressive symptoms or PHQ-9 scores. And for every increase of 1 unit in social cohesion, then depressive symptoms decrease. The same was done for social dysfunction, and social dysfunction explained only 1.3% of variation of PHQ-9 scores. For every 1 unit increase in social dysfunction, there was an increase in depressive symptoms. So social support was also analyzed with depressive symptoms, and of the 3 domains, perceived support from significant others was the only significant variable. With every 1 unit increase of perceived support from a significant other, depressive symptoms decreased. Last but definitely not least is the association of the personal experience of violence and depressive symptoms. And it was noted that as personal experience of violence increased by 1 unit, depressive PHQ-9 scores increased by 4 units. Now on to the discussion. So the findings of this study showed that there were no difference in depressive symptoms in urban versus rural neighborhoods. So this was supported by similar findings from Brown et al., which was stated before as a systematic review of articles in the region. So I also noticed that there was increased social dysfunction that was associated with increased depressive symptoms, which was supported by previous studies done in Jamaica, such as Mullings et al. Social dysfunction was higher in urban versus rural neighborhoods, while social cohesion was associated with decreased depressive symptoms. It was noted that social cohesion was associated with a higher contribution to change in depressive symptoms than social dysfunction. So it was, however, noted to be the same in both urban and rural neighborhoods. This could be a possible reason for there being no difference in depressive symptoms in urban versus rural neighborhoods, despite the urban neighborhood having a higher social dysfunction. So as previously stated, there was an increased social cohesion. That increased social cohesion decreased depression. And this was supported by findings from Robert et al. Other findings suggest that increased social support was associated with increased social cohesion. So social support was associated with depressive symptoms. However, the only type of support that changed depressive symptoms was noted from significant others. This suggests that support from a significant other could either be the most valued or the predominant support received in the sample. And it is with this finding, so this finding supports another study that was done among antenatal patients in Jamaica, whose partner support was strongly associated with the severity of depressive symptoms. In this study, the young had the highest prevalence of depressive symptoms, which is similar to global findings. However, it's not supported by national results. The highest prevalence of depression for Jamaica was in the 75-year-old to the 75-year-old age group. So being female was found to be associated with depressive symptoms, which is supported by findings of the national studies. The experience of violence is known to have a significant contribution to depressive symptoms, and this was noted in this study as well as multiple other studies. So in terms of limitations and strength, so this study was limited in its conclusion due to its study design being cross-sectional. It means that no causality could be determined, only possible associations. This study should have ideally been conducted in the community. However, due to safety concerns to the researchers as well as limited time and funding, it was chosen that it would be best done in the health center setting. The sample size of this study was small as compared to the nationally and internationally conducted studies, and this may have impacted the robustness. The scale used could be seen as a limitation. However, it could also be seen as a strength because in order to assess a person's perception, you need to evaluate these things. So this table shows the internal consistency calculated for the instruments in the study, the MPSS and the PHQ-9s. It had maintained good reliability. However, reliability for the social cohesion tool was a little lower than expected. So in terms of recommendations, the results of this study highlight the importance of investing resources and efforts into programs that provide social interventions, especially in neighborhoods with high levels of social dysfunction and crime. So as family practitioners, both private and public, one could consider organizing group sessions within the communities to ensure the awareness of social programs and counseling that is available in the community, as well as one could become an advocate for special causes. This study also could spark the debate as whether screening protocols for high-risk groups should be initiated. And these are my references. Thank you.
Thank you very much, Martina Williams. That was a really interesting study. And I allowed you to continue. You've actually covered most of your question and answer time. But I was looking at the comments in the chat at the same time. And somebody commented that this was brilliant. We are happy to see a family medicine resident presented at the conference, and we're just excited about that and hope to see more of this. Sam, do I have any time for question and answer for Dr. Williams, or do I move on to the...
As a resident of St. Catherine and being personally invested in the information, I think we can take 2 questions. How about that?
2 sounds great. I'm going to be...
Dr. Williams Green, could I say something? Dr.
Please go ahead.
Here. Not a question, but just a point of clarification. Dr. Martina Williams is actually now a graduate of the family medicine program at UWI. She has her DM in family medicine, and this was her project that she did in pursuant of the DM. So very, very gratified to see her presenting at a forum such as this.
Oh boy, d'accord, as I say in French. So really excited. Just one comment, perhaps. I didn't see the recommendation, but do you think, Dr. Martina Williams, do you think we should add another screening question, such as, have you been a subject of violence or seen been exposed to violence in the last 3 to 6 months, would that help to identify the persons who your study has said was more likely to present with depressive symptoms? Do you think that's a way to look at it?
Yes, that's definitely a way to look at it, because in this study it noted that the personal experience of violence had one of the highest changes noted in depressive symptoms. So yes, definitely.
Yes, thank you. So among the many things family physicians do, we ask about smoking, alcohol use, are you feeling sad? You use the PHQ-2, and we need to add another one. Have you been exposed to violence? I think it's very important, and you've made a great impact this morning, Dr. Williams. All right, Sam, take it away. Thank you so much. Take it away with the presenters. There are 3 sponsors now. Each has 5 minutes. I'm hoping they don't go over. Go ahead, Sam.
So first we'll have Indos. So I invite Mr. Danadan, longtime sponsor and supporter of CCFP Regional and Jamaica, AGPJ, and of course, WFDD. So Mr. Danadan, over to you for 5 minutes.
Good afternoon, everyone, and greetings from Indus Life Sciences for all the participants, presenters, moderators, and sponsors. And thank you very much. And just to briefly remind you what Indus brands, and one is you all know about our antacid that we introduced last year. Sorry, it was in 2022. We launched for those who have these conditions like heartburn, hyperacidity, gastritis, gas problem, and and also GERD. So the first time in Jamaica, the antacid, that was the alginic acid benefit, which basically helps to stop GERD and ensures good night's sleep. Especially at bedtime, if you have a nice dinner and it throws up, it disturbs your sleep as well as a nice dream too. So new gel is there to help you to prevent these GERD conditions, as it forms the alginic acid in new gel forms this alginate raft, as you could see in the slide, and that prevents the acid content from the stomach moving from stomach into the esophagus. So to understand it better, the small clip that we have can explain it so nicely. How does alginic acid works? As you could see here, once they've taken the new gel, as it enters into the stomach and interacts with the stomach acid content, and the alginate raft is formed, as you could see in the clip. And whenever the stomach acid content tries to move up into the food pipe, esophagus, it is blocked. In number of attempts it makes, every time it is blocked. And interestingly, this alginate raft is formed within 4 minutes of taking new gel, and it stays over the stomach acid content more than 5 hours or so. And after 5 hours, what happens? Along with the stomach content, it gets excreted. So this antacid is the first antacid in Caribbean. Not only in Jamaica, it's available in Guyana, Barbados, Cayman, Bahamas with alginic acid benefit, and as a regular acid neutralizing medications like magnesium hydroxide, aluminum hydroxide, magnesium trisilicate. The dimethicone in this is relieves gas. The good news about is a sugar-free antacid, so all diabetic population can take this, and also safe in pregnancy. I mean, first, second, and third trimester of pregnancy, it can be taken. As we say, safe in pregnancy is well understood. It's safe in children less than 10 years. If they need, they can be recommended new gel. And this is over the counter, so no need for prescription too. Patient can go to the pharmacy across Caribbean. This is over the counter. And we also have this extension of new gel, which has a nickname as mother of all antacid, or we call as a miracle antacid. Why we call mother of all antacid? Because this is the first antacid which has the benefit of mucoso anesthetic drug oxytocin, which is similar to lidocaine, but oxytocin can be orally taken, and it relieves gastritis pain, ulcer pain, duodenal ulcer pain, stomach pain. And it has alginic acid, as you could see in the screen, plus the regular acid neutralizing medication, and also simethicone, which is for flatulence or relieves gas. Here I like to highlight, if you look at this acid neutralizing medications like magnesium hydroxide, aluminum hydroxide, magnesium trisilicate, they are in balanced formula of 250 milligram each. The reason is that when it is in balanced formula, it will not induce either constipation or diarrhea. So every aspect has been covered to ensure patient gets the best compliance with new gel. The only contraindication for new gel, not recommended for pregnant mothers and children less than 12 years of age. For them, new gel is better. Because of oxytocin, it is not recommended in pregnancy. And please, doctor, remember, this is an antacid, not a substitute for anti-ulcerant, like your proton pump inhibitors. Any antacid for that matter is benefit for fast symptomatic relief. It can be co-prescribed with your regular anti-ulcerants. And it's available in different pack size. We are the first company introduced in single dose 10 ml sachets on the go. So anybody is traveling or visiting restaurants, you don't have to carry the whole bottle. You can carry as many sachets you want, and it's 10 ml sachets available across Caribbean. And just to refresh you, our vaginal insert Resvi, the gel, which has the carbomer polymer methyl technology, which ensures uniform spreading in when it is inserted with the help of the applicator. And the CPM technology in gel ensures, in Resvi gel ensures, it is retained for longer time, and it is safe in pregnancy, second, third pregnancy, even in first trimester. If there is a need, it can be considered. And that's our Resvi is also available in all Caribbean countries. And the last but not the least, I like to, because today a lot of topic is on mental health, and we need a supplement for, for many conditions. We have this best supplement in across Caribbean. Not only offers all vitamins that we look in a supplement, and the first supplement offers 10 essential amino acids for immediate protein synthesis. And it has zinc as well as folic acid is also there. And who can take AminoPep? Anyone about 2 years of age is right to recommend. Pregnant mothers can take it, and during lactation phase, elderly people, growing phase, anybody can take AminoPep. And just to conclude, WHO always insists, 4 important points for healthy lifestyle. One is a 30 minutes exercise is recommended, and healthy food, I mean, fruits and vegetables to be included in our daily diet, and water, adequate water we have to take because summer is too high now in Caribbean, and at least 6 to 7 hours of sleep is a must. And we just thought we can add one more point. Of course, it's not from WHO, from Indus, begging you to take AminoPep 10 ml a day for a healthy lifestyle. Thank you very much. And for any samples, you can WhatsApp to this number. So we'll be happy to send you samples. Thank you very much. Enjoy the rest of the presentation.
With over 25 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine scans, ultrasounds, X-rays, mammograms, MRIs and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocho Rios. Our MRI services are offered at our Ocho Rios branch, located at White River North Commercial Complex in White River. With cutting-edge technology and compassionate care, experience the difference with our fast, precise and comfortable MRI scans. Also offered are our mammogram services, available at our Ocho Rios and Molines branch. With the highest level of accuracy and precision, we extend our promise in offering the highest quality care. This includes general screening, diagnostics, and tomosynthesis. A breakthrough in breast health, tomosynthesis, or 3D mammography, captures multiple images of the breast from different angles, creating a detailed 3-dimensional view. This means even subtle abnormalities can be identified, ensuring the most accurate results. Your health journey starts here, where accuracy meets comfort. Apex Radiology is the clear choice for your diagnostic needs.
Do we have Medimpex, Jamaica?
Oh, apologies. Yes. Next is Medimpex Jamaica Limited, and their video is up now.
Hello and good afternoon, everyone. It is a pleasure to present at the World Family Doctor Day Conference 2024. My name is Tanjini Turner and I am a medical representative at Medimpex Jamaica Limited. At Medimpex, we are committed to offering first-class products that promote healthy living. Today, I will be discussing Stimuloton, our sertraline 50 mg tablet, which is designed to provide relief from the most challenging symptoms of depression and anxiety disorders. Thank you for your attention as we explore the benefits and applications of this important medication that lifts you from your worst. Why choose Stimuloton? Stimuloton is classified as a selective serotonin reuptake inhibitor, SSRI, which functions by augmenting the levels of serotonin, a crucial neurotransmitter known as 5-HT in the synaptic gaps between nerve cells in the brain. This is achieved by inhibiting the reuptake of serotonin, thereby enhancing its availability and activity. The result is a significant alleviation of symptoms associated with mood disorders, including depression and anxiety. Sertraline, the active component of Stimuloton, is recognized for its potent efficacy among SSRIs, with its clearance from the body not being influenced by age. This attributes allows for the plasma levels and clearance rates of sertraline to be effectively managed. Additionally, sertraline has minimal impact on cytochrome P450 enzymes, which significantly reduces the likelihood of drug interactions. As previously mentioned, Stimuloton is prescribed for individuals experiencing obsessive compulsive disorders, OCD, depression, and panic attacks. For the treatment of depression and OCD, the recommended dosage is 50 mg taken once daily with food. Full therapeutic effects are typically observed after 2 to 4 weeks. In cases of panic disorders, the dosing schedule begins with 25 mg once daily with food, followed by an increase to 50 mg once daily from the second week onwards. The complete therapeutic effects are generally achieved within 8 to 12 weeks. The maximum daily dose should not exceed 200 mg. For special population, elderly patients, no dose adjustment is required. Patients with renal impairment, no modification of the dosage is necessary. Patients with hepatic impairment, a low dose or extended dosing interval may be appropriate. Regarding pregnancy, the safety of Stimuloton is not established. However, for nursing mothers, it is important to note that the drug is excreted in breast milk. Stimuloton represents an excellent choice for patients' treatment option. It is priced at approximately $140 per tab. However, with the assistance of NHF subsidy, the cost is reduced to $45 per tablet. Consequently, patients are responsible for approximately $95 per tab after NHF coverage is applied. This pricing structure ensures that Stimuloton remains accessible and affordable, allowing patients to benefit from treatment without financial burden. I would also like to take this opportunity to remind our esteemed audience about our other pharmaceutical products. These include Tamsol, Melaflam, Amlotor, Cavington Fort, Cleon D, Sorbifor, and Curiosine. Each of these products exemplifies our commitment to providing high-quality healthcare solutions that address a wide range of medical needs. Thank you for considering our diverse portfolio for your healthcare needs, and thank you for your attention to my presentation.
Thank you, Medimpex. And at this time, we are going to proceed to our panel discussion, which is titled Guidelines to Management of Mental Health Pandemic. We're looking at the preventative, treatment, and rehabilitation measures that have worked in primary care. So each speaker is limited. They are sharing 30 minutes, so I would say not more than 3 to 5 minutes each. We have already been introduced to Dr. Kevin Goulbourne, Dr. Ganesh Shetty, and also Dr. Garth Rattray. So just briefly to say, we're also welcoming Dr. Anna Brown Morgan, who is head of the World Family Doctor Day Committee. So special welcome to her. And she was a signature awardee last night. We're also welcoming Dr. Aileen Standard-Bolson, past director or coordinator of the Family Medicine Program, now an adjunct lecturer, and the Family Doctor of Excellence for 2024. And we welcome as well Dr. Donald Gordon, family practitioner of over 40 years, who was also named a signature awardee at the World Family Doctor Day banquet last night. So we're going to ask Dr. Kevin Goulbourne to kick off. Remember your limited time. I will interrupt you if you pass 5 minutes. Please go ahead.
So Williams, and in terms of guidelines in management of mental health pandemic, as was highlighted in previous presentation, anxiety and depression is a big issue. Also, we have to be mindful that there exists a treatment gap in provision of these services within the public system, and I dare say maybe limited in the private system because person may not be able to afford it. Also, we know about the stigma attached to mental illness, so even persons are coming in the public system, they may not be mental services in the mental clinic. Also, we want to highlight the fact that a lot of chronic diseases is associated with depression, and it is estimated about 30% of persons who have chronic illnesses like diabetes, hypertension, are likely to have a comorbid depression. And as you can imagine, a comorbid depression will affect, one, the compliance with the treatment for the primary condition, which is diabetes, hypertension, or other chronic diseases, and will also worsen our outcome because of poor compliance with the other chronic non-communicable disease. Now, we must bear in mind depression can occur at different stages at different ages. Hence, a life course approach becomes necessary when screening for depression. So even youngsters can be depressed, adolescent, as well as an older person. So screening guidelines will recommend for us to screen across life course, adolescent, adulthood, elderly, and to bear in mind the pregnant and postpartum ladies. And the Ministry of Health has actually put forward screening guidelines for these groups, and they're either assessed as average risk or high risk. And usually PHQ-2 is done at the initial stage for screening persons, and the result of it will determine whether they go to PHQ-9. And also frequency of testing will determine by the initial assessment. And having assessed the person and assessed the person to be mentally ill with depression, we also have to bear in mind we have to rule out differential diagnosis. So even when we think we have a positive PHQ-2, we need to make sure we assess is there a differential diagnosis for the symptom presenting. So the person is lethargic. Could the person be a hypothyroid of other medical conditions. So we have to make sure we rule out other medical conditions which may contribute to the person's presentation. I've ruled out other differential diagnosis, then one can proceed to treat the person. If the person is mildly depressed, if the person is moderately severe depressed, then one may refer to the mental health services. And that's where image gap intervention guide comes in training nurse practitioners, medical officers, how to go about assessing, diagnosing, treating person with depression, and to know when to refer those patients for the mental health practitioners to do further intervention and further assessment. So I think with this overview of approaching this way, we can pick up those persons who may be depressed, or we need to have a high index of suspicion, especially for patients who have non-communicable diseases which are not responding, initially responding and not responding. We have to also bear in mind that it could be a comorbid mental condition which may be causing a poor outcome in terms of diabetic control, hypertension control. So we need to always bear that in mind, even in our basic clinics, even do the PHQ2 to make an initial assessment and assessment follow up on the screening guidelines which will be made available from Ministry of Health. Thank you.
Thank you. Thanks much for that timely reminder of looking out for organic causes. We're going to make a little change. Dr. Aileen Standard-Wilson will go next. Please go ahead, Dr. Standard-Wilson.
Thank you very much. Appreciate it, because my internet has become unstable and I'm hoping that it will hold up. I am trying to just share my screen. Sorry, are you still hearing me?
Still hearing you. And
okay.
We're beginning to see your screen.
All right. Okay. I just want to thank you for the opportunity of presenting today. And sorry, I want to try and get this into presentation mode. And I just want to say today a few words about the MH-GAP intervention guide, which Dr. Goulbourne mentioned earlier. Over the past decade, I've been very privileged to be trained by PAHO and engaged by PAHO as a tutor for delivering courses using the MH-GAP intervention guide. I've done a number of training sessions with them, and I have been tutor at MH-GAP sessions for healthcare workers across the Caribbean, places such as Dominica, St. Kitts, the Cayman Islands, and the Bahamas, and also on the virtual public health platform where participants from over 12 Caribbean countries would have been involved. I think it's an excellent guide that our family doctors should become more familiar with. In its hard copy, this is what the MH-GAP intervention guide looks like. This is version 2. Version 3.0 is currently in production. And what this is an evidence-based clinical guide for the assessment and management of mental, neurological, and substance use disorders in non-specialized centers. So in other words, not by psychiatrists, but by family docs or other primary healthcare workers in the community. It's one of many tools that WHO has. And it is available, freely available. If you just Google and put in this, you will get a online copy of the intervention guide. Now, why train primary care doctors to deliver mental health care? We have heard about the global burden. We have heard that these conditions occur concurrently with chronic health conditions, and that people with mental health problems are challenged by stigma that worsens their quality of life affects social inclusion, employability, and interferes with health seeking. And many individuals remain untreated even though treatment exists. The WHO, World Health Organization, and the World Organization of Family Doctors, WONCA, 2008 publication, highlighted the integration of mental health into primary health care as the most viable way of closing the mental health gap. And certainly you see that our Ministry of Health is has moved in that direction. The importance of training primary healthcare workers to assess, manage, and appropriately refer patients with mental health problems was emphasized and remains part of the WHO initiative. The Mental Health Gap Program, the MHGAP, is the WHO program to scale up care for mental, neurological, and substance use disorder and was launched by the then WHO Director General in 2008. The current module has current intervention guide has 9 modules that you see listed here, and the version 3.0 is going to add anxiety, which is one of the things that we thought were missing from this iteration. It gives an overview of what the common presentation is, guides you to what the priority condition may be, and then it also provides information on emergency presentations and how these could be dealt with. And for each condition, it provides an algorithm that guides you through how to make a diagnosis. For instance, if we look at depression, just as an example, so this is one of the things that we as family doctors should be managing more in our private or public settings. And it will tell us what the common presentations are, and then ask the question, does the patient have depression? The questions here are the same as on the PHQ-2 that you asked about. If those are present, then you go on further to ask things that would be found on the PHQ-9 to see if these symptoms are present. Then the algorithm takes you through to say, do these symptoms cause a difficulty with daily functioning, which is the hallmark of determining if there is moderate to severe depression. If this is so, we as was just Dr. Goulbourne was just saying, you asked, are there any other possible explanations? Hypothyroidism, anemia, medication side effects that could be causing it. If this is ruled out, the algorithm takes you through and reminds you that you have to check for a history of mania, because if this person has had an episode of mania in the past, this may not be straight depression, but it may be a depressive episode in a bipolar disorder, and it will take you to the part of the guide which would tell you how to treat that. Also, you need to check has there been a major loss or bereavement in the last 6 months? Because if there has been, the treatment or the management would be a little bit different. And then it just takes you through in a very nice way to see if there are any other concurrent conditions that you need to take care of, and it brings you to your diagnosis of depression. It is a useful tool that I would, and all the different sections, the 9 modules that are there have very useful reading material, background reading material, the algorithms to guide you. I know that there has been training, as I said, across the Caribbean in a number of health systems. And I know our own ministry has had training in MHGAP prior and planned to continue this. And we certainly use it in the family medicine program as well for training our family medicine residents. And I hope that organizations such as CCPJ and AGPJ will consider collaboration to ensure that our private family doctors are also exposed to this useful tool. So those are just my few words, just to bring knowledge of the MH gap to the wider audience.
Great. Sounds exciting. And I'm sure that both organizations, or at least one, will take up that mandate, that charge. Definitely, we need to get on board there. And we can help to spread it right across our country and the Caribbean. Now we're going to ask, is Dr. Ganesh Shetty here, or should we move on? I'm not seeing him.
We should move on. I think he left to,
okay,
I think he got a call.
All right, you understand that we appreciate what he presented. It was so exciting. So now we'll go on to Dr. Anna Brown Morgan. This is how I have it in my list here. So Dr. Morgan, please go ahead. Thank you.
Okay. I'm going to share slides.
This looks like a help Sam moment.
No, man, I'm sure Dr. Brown Morgan has it. She shared screen a while ago. I think she was just looking for a PowerPoint. Share screen once more, Doc, and then we'll find your PowerPoint.
Okay. Yeah. Okay. Can you see my PowerPoint now?
You're not sharing screen.
Not seeing it just yet. All right, luckily we have backups. Dr. Brown Morgan ensures that we have a copy just in case. All right, so we have it up here now for you, Dr. Brown Morgan. Go ahead.
All right. Share screen. Again, or I don't know. I don't need to do this. I don't know why every time I have this problem,
So I have the screen shared for you, and I can switch the slides. Would you prefer to share? You want me to stop and let you share?
I would love to do it myself.
No problem. So let's go ahead. So come back to Zoom, click on share screen.
Come back to Zoom.
Click on the green button. Sometimes it's blue. It says share screen. When you click on share screen, at the top you'll see basic advanced files. Where I want you to click on basic, and then you're gonna see desktop 1, whiteboard, and under that you should see your PowerPoint.
Basic. And then whiteboard.
And below that you should see your PowerPoint. You should see Microsoft PowerPoint, and you should see your PowerPoint.
Okay. And then I can share now, yes?
If you click on that and click the share button, it should bring up the PowerPoint. Perfect. So we're now seeing the PowerPoint. It's just for you to send us into full screen mode.
New share?
No. You're now in your PowerPoint. So on the PowerPoint, you can click on Enable Editing, which is right at your cursor there to the right of it. There's an Enable button there. You can click on that, and then we can go to slideshows, play from the beginning.
Sorry.
That's all right.
All right. Okay, am I there now?
Sure. Right. We're there with you now.
Thank you.
Perfect.
Oh my gosh, I'm getting there eventually, Sam. I have this problem all the time. It must mean something. Anyway, during the pandemic, I just wanted to say that a lot of what I have to say seems to be what Dr. Standard Golson has said, Dr. Rattray has said, and what Dr. Goulbourne very nicely has said that the government is doing. Because a lot of what we need to do now is not just based on what we have been traditionally doing in our offices. Going forward in the future, we need to do a bit more. So with this slide, during the pandemic, rates of the anxiety and depression, as we said already, increased by over 25%. And many clinicians came to the conclusion that the one-size-fits-all approach to mental health just isn't the answer. Different cultures had different challenges, required different solutions. So, and even post-COVID now, people are just not feeling normal. There's this sense that, like, we're on a question sign, we're on a point. We need to normalize our society again. So across all ages, as Garth said, Dr. Rattray, over a fifth of all adults reported feeling anxious or depressed. And the vulnerable population, the children, the adolescents, the elderly, unemployed, homeless, all these people have been mentioned, the grassroots workers, people with disabilities, people with chronic diseases, bisexual and transgender. So guess what? This is like literally everyone. And their problems that they've had psychologically since the time of COVID has been almost unmanageable. The silver lining of the pandemic, if there is any, about this mental health disaster, is that we've all started to talk about it and bring it more to the front. So we just need to also know that people who were affected by the COVID-19 infection, disorder, the disease, and had, you know, outcomes like stroke, and I mean, we had that set of people as well who are gonna have psychological and psychiatric conditions. So it's not just the isolation and the lack, the loneliness, but it's also the psychiatric outcome of disease, bad disease outcomes. So some patients directly having mental illness because of their COVID disease. And then there are those with the death, you know, so many of us, as Garth was saying, the death of caregivers, the death of a neighbor. I had the death of a neighbor. I had the death of a cousin. The loss of academic access during the COVID time with people failing exams. There are now just a myriad, it goes past the whole society of how problems that are there to be resolved. So we now need to think outside the conventional medical box, where we see people coming to our practice as primary care physicians, and we think, okay, they are depressed, or they are anxious, or they're drinking too much alcohol. How do we help them? How do we maybe counsel them? What can we do? Are there any, you know, medically related agencies? Now we need to think that we need to look at the entire scenario, bigger still. It's integrative medicine. It's holistic medicine. It's One Health. Because here we are now is that, for example, if somebody is depressed because they have failed an exam, it's not enough to say to them, you failed the exam and okay, you can feel better. How do we help them to get back in the system? The educational system, what are the links that we have to this system that will enable us to help this patient? Same thing as Dr. Henry was saying earlier. If you lost a home in a hurricane, how do you deal with this? Where you're not going to ever be just normal again unless you get some help. You need some help with somebody to relate to housing. So we need our next generation of professionals to be able to meet more well-defined, the needs of our patients are more well-defined and not just structured just to the one medical access. So we should be promoting mental health and wellness through the promotion of healthy lifestyles. We should be using traditional and social media for mental health awareness campaigns, as we should be supporting community support and establishing primary screening services, as Dr. Goulbourne was telling us about, establishing a national suicide prevention helpline, integrating basic medical health. I think this is being done as well. Developing self-health, and also ensuring financial support for people who have lost so much through our governmental and non-governmental organizations. There is an urgent need to address these current unmet needs. Some in the some are coming, but we just need to know that they are urgent and they need to come now. So that's part of the challenges that we have: the paucity of human resources, paucity of infrastructure, the burnout of the mental health professionals, which has resulted in increased levels of mental health issues. If mental health disorders in health workers remain unaddressed, then these professionals cannot provide efficient mental health services for their patients. So we have some other areas in which we can give help. We can push the telepsychiatry. There are patients who cannot come to you, and sometimes those of us who are more techie can start to see a greater number of patients, especially those with mental health problems, this way. And the government itself could have a platform centered on community health services, which will enable this type of care among vulnerable populations. As again, Dr. Goulbourne, national health policies designed to provide integrated care for medical health in different settings. Integrated healthcare for mental health people in hospitals, in the primary care services, in the communities, in the schools, in the universities, and the workplaces. We all need to link cohesively. This has to be a overlapping access where there has now to be greater linkages established. We have to formalize the liaisons between these settings with the mental health services, and this would help us to promptly identify and holistically address emerging mental health needs. So we need to develop support groups. Screening of at-risk groups within the primary care needs to become like, we have to do it we can have somebody in our office do it, or we need to do it for all our patients. And Dr. Standard Golson just introduced us to a tool which we can use well in this setting. So we need to establish crisis helplines, and we need to expand our support services to facilitate mental health needs. Community mental health services should screen, identify people at risk, provide psychological first aid, and facilitate onward referral services. Primary healthcare workers and pharmacists, geriatric caregivers, school teachers, these people should be trained to identify individuals at risk and to direct them for proper evaluation. We see so much violence happening in our schools, so much killing and so much pain. And we need to identify this in individuals before they happen. And we need to have a general linkage, much more organized linkage, so we can link together and get these people, get these youngsters early help. Grassroots workers should be trained in identifying and managing pandemic-associated psychiatric and psychosocial issues. So for the layperson who is listening now, talk about your feelings. Just being listened to can help you feel supported and feel less alone with any problem that you're going through. Get a good night's sleep. Don't just, sleep. Don't stay up all night. Don't say, okay, I can't sleep, I'm gonna watch TV. Try to sleep. Sleep and mental health issues are closely linked. And a mental health issue can affect your sleep and vice versa. So recognize that your anxiety can be normal. Find a distraction, connect with your friends, focus on yourself, connect with these feelings. Be kind to yourself and others. Get regular exercise, eat healthily, make sleep a priority, try relaxing, set goals and priorities. Practice gratitude. We have so much, even in the midst of all of this, to be thankful for. Life is not all dark. There are wonderful things that are still happening in this world, here in Jamaica, and in our own lives. Hold on to those things and look at them. Take them out every now and again and say, wow, isn't that something? Feel good. Focus on positivity and stay connected. So, and also preventive measures. Prevent yourself from developing depression and other mental health issues by staying healthy. And this means seeing your doctor at regular intervals, doing your blood pressure, checking that you're not having diabetes, do your cholesterol test, do your cancer screening if you're over age 40, 50, and quit smoking, lose weight. And if you have a child, make sure they're not missing their regular visits. Talk about your feelings and tell your friends how you feel. And think about seeing a therapist. Think about seeing a therapist if it feels like a heavy burden. Do something you enjoy. Doctors, your patients need you. Family physicians are in the best position to address behavioral health. Up to 80% of people with a behavioral health disorder will visit a primary care physician or other primary care provider at least once a year. So moreover, some patients would rather seek help from their primary care physician than a specialty mental health provider. And we know it's the stigma, but they can come to you and they feel it's about anything. So sometimes you just have to go with that flow until we can establish and destigmatize the whole mental health issue. Research has suggested that in addition to pharmacotherapy, brief psychotherapy for depression can be delivered effectively in primary care. But there are times when primary care physicians really need to refer their patients to behavioral health specialists. Don't watch a patient declining. You're trying, they're on a plateau, they're depressed, it's worsening, please refer. But we need to know, however, up to 50% of patients referred may not go to their first appointment. So you need to check up back on these patients so you don't lose them. You will be a better doctor after treating your patient's psychological illnesses. You shouldn't be surprised when their physical health improves as well. The risk of cardiometabolic disease is up to 2 times higher in individuals with mental health disorders compared to normal individuals. And patients with depression have a 40% greater risk of developing cardiac disease, hypertension, stroke, diabetes, metabolic disorders, even obesity, than the general population. Additionally, most of the evidence out there identifies increased levels of physical inactivity, sleep disturbance, smoking, alcohol, excessive consumption, and poor diets in many patients with mental health diagnoses. So by addressing your patient's mental health, you will likely help them and improve their physical health as well. I thank you.
Thank you, Dr. Anna von Morgan. Anna, you broke my rule, but you gave us such interesting thoughts. And so we're going to give, so I have Dr. Garth Rattray and Dr. Donald Gordon. Garth, I'm going to give you the last word. So let's ask Dr. Donald Gordon to speak on the topic. Go right ahead for me, Dr. Gordon.
Thank you, Dr. Williams. Good afternoon to my fellow panelists and the audience. And thanks very much for the invitation to present on this panel discussion, guidelines to management of mental health pandemic. Now, a lot has been said about the mental health pandemic by the previous speakers. So I won't duplicate a lot of what has been said. I will emphasize certain points. Can you go to slide number 3? Okay, let's look at the etiology of mental health issues in the pandemic. Basically, simply, it is caused by excessive stress from pandemic situations, the isolation, the separation, job losses, not able to see a friend. And this, when this is combined with a lack of proper coping skills in vulnerable groups, combined with inadequate social support, inadequate material and financial resources in the vulnerable groups, then you'll find that there's stress, then develop the stress of anxiety and depression. Can you go to slide 4? Some of the groups that are very vulnerable to mental health issues are young adults, adolescents, and children. Young adults, especially, they lose their job opportunities. They are disrupted from their education. They can't continue their college because college is closed. Adolescents, they are isolated from their friends. Children, they are at home, sitting at home, not doing anything. Other vulnerable groups are the socially inadequate groups, groups that are less educated, persons who are lower socioeconomic persons, persons who have financial insecurity because they are minimum wage earners, they don't earn a lot of money, they live from hand to mouth, and therefore a pandemic usually brings on a lot of financial stress on them. Persons with coexisting chronic diseases, persons who are diabetic, hypertensive, they can't see their doctor, they can't go to the clinic, they can't work to fund their medical treatment. All of these leads to deterioration in their chronic medical situation. As a result of that, they go into depression and they become more ill. Let's look at these groups and let's see how you prevent mental health issues in these groups. One of the ways to prevent mental health issues in these groups is to build resilience in these youth groups. For children, young people, you need to teach positive values. You need to teach them that not everything on social media that they see, they should emulate, or not everything on social media is true, not everything on social media is positive. Teach children to have a positive mindset. In other words, they need to know how to image themselves and have a positive attitude about them. Teach themselves how to have positive attitudes about themselves. Teach them where to find adequate social support. A lot of times children are having problems and they don't know where to find the proper social support. Whether it be in school, counseling, whether it be at the church, or whether it be in the community, or whether it be amongst responsible adults. Teach them the value of mentorship and the value of role models. Oftentimes, adult children will relate to an adult who is not their parent, and they will share things with that adult. So, teach them that they can find mentors who they can confide their problems. Encourage them to be a part of socially supported groups at school, for example, school, cadet, 4-H clubs, because they find camaraderie in these groups, and they find support in these groups, they find friends in these groups. And, teach them the benefit of relaxation and stress, the avoidance of substance abuse. And, if you try to do that, then, you'll help to build resilience in youth groups and help them avoid some of the pitfalls of stress and depression in the pandemic. Let's look at adults. In adults, you have to teach adults to maintain good and healthy lifestyles. Example, benefits of diet, exercise, teach them sound financial discipline and habits. Because one of the things that you find about adults is that they oftentimes run into financial problems, and these financial problems lead them to bankruptcy and lead them to very poor health. And touching on management of chronic diseases, persons who have poor health or chronic issues, they can burn up all their financial resources just by trying to cope with their medical problems. You have to teach them to engage and maintain relationships with supporting social groups, like in the church or at the workplace. If they have a union at the workplace, then they can speak with their union who can offer them some amount of counseling and financial support. And you encourage them the proper management of their chronic medical conditions. Because oftentimes, in a pandemic situation, the medical conditions of a lot of these persons tend to deteriorate. You have to teach them to practice emotional regulation and the practice of mindfulness. Teach them how to regulate their emotion, not to get stressed out by too many different situations, because all of these situations tend to occur, and they need to be able to manage themselves in this situation. Rehabilitation in primary care. First of all, we have to raising the awareness of mental issues in patients. Let them know when they are depressed or if they are going into depression. Let them know, when their chronic condition is going out. Let them know that when they're not sleeping well. All of these things, these are signs that point them that they might be going into a depression. How to identify and access mental health resources in the community, because some of the mental health in this community, sometimes it's not readily obvious or it's not readily available, and they need to know where to find it. And you have to teach them to prioritize the practice of health and wellness in their behavior. In other words, they should exercise, they should sleep properly, they should have a proper diet, and they should avoid substance abuse and addictive behavior, because a lot of adults tend to enter into addictive behavior, especially when they're stressed. They will smoke, they will gamble, they will, go out and spend alcohol and spend money on women. So, you have to teach them to avoid some of these problems. And once you teach adults and children how to build resilience, you'll find that they'll be able to cope better when these problems come along. And that concludes my presentation.
Thank you very much, Dr. Gordon. And the final word goes to Garth.
Yeah, I'll be very brief. Nothing more to say. Everybody said everything, but I want different perspective. Before the pandemic, we had bad problems with stress, with emotional stress. We had problems with mental health. Pandemic came, and now we have a pandemic of mental health. This month is Mental Health Awareness Month. Most people don't know that. They know about Reggae Month, they know about Child Month, they know about Heart Month, they know about Black History Month. Ask people outside, what month is this month that people don't know? I have to blame us for it, because we're not really doing what we're supposed to do. we have a big voice, you know. We have a big footprint. Trying to find something to tell you, to show you. There's something they did a few years ago called let me tell you, Global Trustworthiness Ranking 2021. Doctors, when they did a survey, 6% of people trusted doctors, and bottom of it was politicians. 10% trusted politicians. You'd be surprised to know, but only a quarter of people trusted ministers of religion. I talk about priests and so on. 25%. Even police, 37%. Armed forces, teachers, 55%. We were top. But are our voices being heard? No. We keep it to ourselves in our offices. We need to get out there. I mean, here, we know everything. We know what we're supposed to know, but it's not getting out there. People should write in newspapers. They will take articles from you, and I can tell you that the Gleaner wants it. Put your voice out there. Now, the Ministry of Health is doing things, but as a government entity, and as I said before, politicians, they don't trust politicians, and they know it's a political entity. All I'm saying is that I heard everything already. Everybody heard everything already. It's our time to put it out there. This is Mental Health Awareness Month, and people don't even know that. We are talking about it, and they don't know. That's all I have to say. Thank you.
Perfect. Well said, as usual, said succinctly. And what an important point to end on, that, yes, we know a lot, but we need to put it out there. And we're seeing many persons over the passage of time, of a day, a week, a month, years. We see so many persons as family physicians. It's our right, our duty. I think that's what Garth is saying, to make sure we put the messages out there. So thank you, panelists. Dr. Kevin Goulbourne hung on for as long as he could. He was obviously on the road, so he stopped and he joined us. Dr. Anna Brown Morgan, Dr. Aileen Standard Wilson. She was having internet issues. I'm not sure if she's still there. Dr. Garth, Rattray, and of course, Dr. Donald Gordon. Not in that order, but you all gave insightful comments and shared with us, both as doctors and I like what Anna did. Anna reached out to the regular public person in the population. I haven't forgotten Dr. Martina Williams, who really, incited our research interest and made us feel very proud of the family medicine program. At this time, Sam, if it's all right with you, I don't think we have any more sponsors. Is it okay to hand over to Dr. Seni Onanuja for the vote of thanks?
That would be perfect.
Perfect. Thank you all for having me. I could have tightened the ship a bit more, but I think we got such good information. Bless you all. Dr. Seni?
Good afternoon. Oh boy. Good afternoon, everyone. Ladies, gentlemen, esteemed colleagues, and distinguished guests. This has been a wonderful morning and afternoon. As we draw close to, on this year's World Family Doctor Day, Virtual Continuing Medical Education Conference, it is my great privilege to offer a heartfelt vote of thanks to all who made this event a success. The theme, Preparing for the Mental Health Explosion, the Role of the Family Physician, reminds us of the crucial role we play in addressing mental health challenges within our communities. First, I'd like to extend our deepest gratitude to our moderators, Professor Marvin Reed and Dr. Pauline Williams-Green. Your expertise and thoughtful guidance ensured the smooth running of today's conference. Thank you for leading us through the program with professionalism and warmth. To our speakers, thank you for your insightful presentations and discussions. You shared your expertise on a range of important topics from artificial intelligence in asthma to the rise of mental health diseases post-COVID-19 and others. A special thank you to Dr. Terry, to Drs. Terry Baker, Kevin Goulbourne, Ganesh Shetty, Garth Rattray, Martina Williams, and all the panelists in our final discussion, which also included Dr. Aileen Standard-Gosin, Dr. Anna J. Brown-Morgan, and Dr. Donald Gordon. Your contributions have provided us with valuable knowledge and practical approaches to improve mental health outcomes. We are also deeply grateful to our sponsors, GSK, Heart Foundation, Partners Heart and Health, Medical Protection Society, Abbott Nutritional, Health 2000 Canada, Indus Life Sciences, Apex Radiologists, and Medimpex Jamaica for their continuous support of our activities. I hope I have not forgotten anyone because you are all very important to us. Your generosity makes conferences like this possible, and we appreciate your commitments. Advancing family medicine and promoting mental health awareness. Thank you for your support. A huge thank you to the members of the World Family Dr. Day Planning Committee, chaired by Dr. Andrea Purare. Our team members, Dr. Aileen Standard-Gosin, Dr. Donald Gordon, Dr. Anna J. Brown-Morgan, Dr. Aldith Buckland, and yours truly. Let me not forget Dr. Dane Levy, our secretary and very able person. And yours truly, your dedication and treatment, teamwork ensured a successful event. Your hard work behind the scenes did not go unnoticed. I hope I didn't forget any of our team members because they did a lot of work behind the scene. A big thank you to our IT support team from Oldgate Solutions, led by Mr. Samuel Heron. Your technical expertise and prompt assistance were key to the success of our virtual platform. And to the administrative team of the Caribbean College of Family Physicians Secretariat, Lynn Thompson Hyatt and Suyan Lawrence. We thank you for your behind the scenes coordination and support. You are the unsung heroes who keep everything running. Finally, to everyone who joined us today, thank you for your participation and engagement. Your enthusiasm and curiosity made the conference truly special. As we continue our journey in family medicine, let's keep in mind that the greatest wealth that we have as human beings is health. Let's work towards a healthier future for all. As we move forward, let's keep in mind the words of Maya Angelou. Try to be a rainbow in someone else's cloud. As family doctors, we have the power to bring hope and healing to our patients, especially during their challenging times. We thank you once again for being part of this important event and for your dedication and support. We look forward to seeing you at our next event and continuing this important work together. Have a wonderful day. Stay safe. As always, wishing you all God's richest blessings. Thank you.
Thank you. Thank you. Have a wonderful day, everyone. The post-test link will be shared now. Have a great day.
Could you put the process back, please? I'm not seeing it.